I got a couple of vertical head nods for those who are virtual. So let's talk about, next slide, let's talk about affordability in healthcare. And that's some of the work that the Alliance has been doing for a while. We've done a total cost of care report. We've been looking at equity. We can see that costs and risk and everything gets worse when you're in more deprived neighborhoods. But one of the things we wanted to explore is, what's really causing that. If you go to the next slide, the question that we had and sort of the title for today is, if we spend more, don't we get more? Do we get better care? And that's what we ultimately, all want. If you go to the next slide, this is a very complicated graph and it's very colorful, but it sort of says two things, right? So over the last couple decades, wages have been going up a little bit. Other things have gone down, so car prices have gone down, TVs, your cell phones, all those costs have reduced. The one at the top is hospital costs, and that has far exceeded the average wage earner. So when people are upset that the economy is tough on them and inflation is tough on them, it's because they've had to move a lot of their income into paying for premiums and paying for medical care. And key in there is sort of the hospital side of that. And over those 20 years, hospital admissions have gone down. They've moved to ASCs, they've moved to the outpatient setting, which is great. But the percent of care for hospitals has remained the same, which doesn't intuitively make a lot of sense. So if you go to the next slide, we produced a report. We released it in May. It was funded by Arnold Ventures, and what they wanted to know was, what's going on in Washington? Can you array those hospitals in a way that makes sense, that we can start understanding sort of where those costs are to start the conversation? And so today we are starting that conversation. And if you haven't looked at it, please go out and take a look. The next slide is really about methodology. I am not the methodology guy, but Will Fox will be up here, and he will talk to us about that. But we wanted to get a way that could be consistent, reliable, repeatable, and so we used Milliman to take our claims and convert them into what's called a global RVU. It's a way to basically case mix and severity adjust all that data. We then calculated a conversion factor on that RVU, so that commercial rate, and then we compared it to the national Medicare conversion rate. Now we said, well, why didn't you go in and do each hospital and do their actual Medicare and their geographic mix? We wanted to have it comparable across. It's directional. It's not, we're not paying a claim or anything like that, so we wanted just to know sort of where are we in those things. And if you have other questions about the methodology, we'll get Will to talk about it. The next slide is really sort of the high-level results. So what we did is we looked at acute care hospitals, critical access hospitals. Other people haven't looked at these, but we looked at cancer hospitals and children's hospitals because they are part of the mix and they're part of what employers are spending. And on average, when you take inpatient, outpatient, and all physician services related, or professional services, mostly physician, related to those events, on average, commercial payers are paying 288% of Medicare. So almost threefold of what Medicare pays for the same service. Children's hospitals a little bit more. Critical access hospitals a little bit more. Critical access hospitals are really important in our state. They're all around the state. But they're a small percentage of the total dollars. They're under like 5% of the total hospital dollars that we saw. So while they are paid more, they're not necessarily breaking the bank per se. But I still think they have to be looked at in terms of why one place is getting paid a lot more than another. On the next slide, you'll sort of start seeing some of that information. Inpatient, we paid even a higher rate. Facility outpatient, so those are ERs, outpatient surgery, those types of things, right around 300%. And then the physician services are probably the most consistent ones in there, right around that 180% of Medicare. And so for the physicians in the room, they're going like, wait, I need a raise. But you can sort of start to get a sense of that. What we then did is we started, wanting to array everybody in a list. And so on the next slide, you won't be able to read this, but if you go to the website, you can see it. This is all the hospitals listed, how they array by the lowest cost, if you will, to Medicare at the bottom, the highest at the top. You'll see a couple of different colors in there. Those are because critical access hospitals are one color and acutes are another, and et cetera. And then there's bubbles. And if you go to the next slide, the bubbles represent the amount of dollars spent in each of those places. So some of them look like a little dot because there's not a lot of dollars there, and others are much larger because there's a lot of dollars there. And here's where you start seeing some of that variation in there. So almost a four-fold variation from the lowest to the highest. Critical access hospitals, acute care hospitals, when you remove children's and the cancer hospital, they're about threefold, but it's a threefold difference. And so you have to start wondering, why is that? Now, the other piece to all of these claims is these are the allowed amount, so it's after deductions and all that stuff, right? It is not what care costs, because that's not how we pay for things. We pay for things on a negotiated rate on the commercial side. So this is a negotiated rate, and so you go, well, why are some at the top, why are some at the bottom? I'm not the one to answer that one, but maybe the panel will make us do that. On the next slide, you'll see inpatient. So we arrayed it this way as well. Now you got a five-fold variation. Most of that's because at the very bottom, you see a couple of pretty low hospitals, and at the very top, you see a very high hospital. Acute care hospitals, critical access hospitals, again, 3.6 times variation in what they're being paid on the commercial side. And I can't imagine that one of those hospitals costs 3.6 times more than another one, but maybe that's true. Outpatient facility on the next slide, same kind of story. Now you're six-fold difference with that. And for those in the room or those that can see colors really well, at the top of that list, they're all green. And what green means is those are the critical access hospitals. And you can sort of go, well, shouldn't they get paid a little bit more because they're critical access hospitals? I can't answer that one either, but they're also little tiny dots, but they're all at the top. And at the bottom, you see mostly blue, but you see a couple of greens down there too. So you have critical access hospitals that are able to make it at a much lower rate. And then the last slide, which is over here on the professional side, now the green and the blue, for those that can see it, have reversed. So the critical access hospitals, those professional services tend to be paid at a lower rate, not at a higher rate like the outpatient was. And then more and the more urban centers tend to be the more blue, if you will. But there's a combination of all those things. And people, you can look up your own hospital and take a look at it. Much less variation on the professional side. The other thing we did was we wanted to start looking at kind of where in the state things are. So if you go to the next slide, we looked at health service areas, and we wanted to kind of group hospitals in certain settings. So if you looked at this slide, you see a bubble. If you're online, you could hover over that bubble, and it'll pull up a bunch of hospitals that might be in that bubble. So, for instance, Seattle, you're going to see all the Seattle hospitals. Tacoma, you'll see all the Tacoma hospitals. Some of them will only have one hospital in it because that's kind of the way they are. On the next slide, you can also hone in on certain geographic regions. And so I pulled this one because it's sort of all in the same area, but it is also the lowest and the highest priced hospitals, all in the same region. So when we start thinking about, well, staffing costs are different and capital costs are different, and well, it's probably not that different when you're 40 miles apart in a rural setting. And so why those are so varied is a little hard for me to understand. And then the next slide is really looking at sort of the hospital referral areas. So this is where they go for their big procedures. And we just thought it'd be interesting to look at because you know, where someone like in Aberdeen sort of bypasses Tacoma completely and goes to Seattle. Thought that was interesting. And then Spokane has a big reach. So almost, you know, a big chunk of Eastern Washington, you know, they funnel into the Spokane region. And then you can't see it anymore, but down below, they funnel down south in the Portland area. So you see these little arrows going back and forth. If you go to the next slide, what we looked at was really just the price. This is what employers are spending. This is the allowed amount, but it's not what it costs to run a hospital. It's not their operational costs. It's not you know, what it actually costs to deliver care. But there's a way to measure that, and there's a way to start thinking about that, because what you want to get to is what should the price be for delivering that care. Ideally, it would be, let's do cost accounting and let's see what it costs to deliver X, Y, or Z, but we don't do that. We could, but we don't. So the next slide is a pretty simplistic view. I worked for a hospital for 18 years, actually 21 years now that I think about it. Hospitals have expenses. They have operating expenses. Most of those operating expenses are related to direct patient care. That's nurses. That would be sort of the labor cost for nurses and other clinical people. You've got supervisors, managers, you've got capital, you've got other services supporting that direct patient care. So that's all in that hospital patient care operating cost. But hospitals have other, you know, other costs as well. And so those are called the Medicare disallowed, but they can be research, they could own an apartment building. There's a lot of things that they may have expenses on, M&A, you know, et cetera. So they have some expenses that are not related to direct patient care as well. The next slide is an example of that, and I just pulled a hospital that I happen to know very well after 18 years. This is their distribution of where their costs go. So the salmon is your nurses, your rad techs, your physical therapists, whoever's in the hospital. So they spend 28% of their dollar on those labor costs. And does that seem like a high enough number for you? No, okay, just checking. Just seeing if people are awake. The yellow is their management and supervision, so that's sort of your administrative costs. Green is capital. Blue is all those services that have to support, you know, your engineering and those types of people to support some of the care that's being done. And then you've got this sort of, I don't know what color it is, purple or dark blue up at the top, and that's this other category. So this is other expenses that a hospital has to incur for other businesses they may be doing. And that number tends to vary pretty widely among the hospitals, and I'll show you a couple of examples in a minute. What the right number is for that, I don't know. Is it 30%? Is it 20%? Is it 50%? I've seen all of those when you look at Washington hospitals. The highest I've seen is 51% in a Seattle-based hospital. 51% of their expenses are not related to patient care, right? But you have to pay for that. So, because they have to make do. But I don't know what that 51% is for. Maybe it's bad business decisions, maybe it's, so I don't know what it is. So if you go to the next slide, let's figure out, well, where's the dollars come in, right? So thinking about operating revenue, right? So you've got net revenue coming in, so this is, you've taken out all your discounts, you've taken out your bad debt, all that stuff, and you subtract your operating costs. It should come out positive, right? Because you still have these other expenses you got to deal with that are not patient care revenue. Does that make sense? It's, you know, simple accounting for, you know, a zoology major, which not a, you know, I have to keep it pretty simple. The next slide kind of gets a little bit more, because you also have to figure in, if you're looking at really your net, and I think that's where hospitals get, you know, have had challenges, is their net has been the problem, not their operating margin, right? Because the net has a lot of things in there. The net could have other income, right? So you may have a research grant that may or may not fund your research staff. So if it funds it, great. If it doesn't fund it, it's a loss, right? You may have other things like pharmacy costs and other things like that that you may be another line of business that are not related to the direct patient care that was occurring. You may have made an acquisition. You may have bought some things that are floundering, right? You may have a medical office building that doesn't have tenants anymore, and now you're taking a loss. So there's a lot of things that can go into that other expenses. So let's look at how Washington does when you look at discharge. And if he goes to the next slide, I pulled this from Maryland's work. Thank you, Maryland. It's pretty simple. The bottom line is the national numbers. The top lines are Idaho, Oregon, and Washington. All do about the same. And this is what they've reported in terms of their net revenue, net, per discharge, right? So it's about $18,000, maybe a little bit less, right? Better than the national average. And you say, well, that's great. Next slide is what it costs them to deliver that. So it costs them more, right? All of them. So than the national average. So about 16 and a half or so, a little bit more. And then the next slide gives you what sort of that net is. So that operating profit or operating loss, net revenues minus your operating expenses for direct patient care, about 1,300 and some change. That is exactly the same number as the national numbers. So from that standpoint, Washington's doing, kind of in the middle. Oregon does pretty well. That's the top line up there. So that's great. And that translates to a profit margin of about 10%, right? And so, I mean, people in retail would say, I would love to get 10%. People in tech would say that's not enough, right? So, but 10% seems like it could work. But you remember, we got these other expenses in there. So if you go to the next slide, those other expenses are what has been driving, especially in 22, the concern from hospitals that, hey, wait a second, we're losing money. Now, nationally, hospitals did, a 2% margin, not as good as what they normally do, which is around 4. 21, you got big influence of money from, government payments and things like that. But things reverted, people went back, people were sicker, all of those things. But we missed on that, and Washington is missing something in there in terms of not being at the national average because we're kind of below all the way along. So if you go to the next slide, it sort of asks a few questions, right? Why do other hospitals do better? Good question. Employers are having to make up that difference. So because of some other business decisions, we have to pay a little bit more. We're getting more pressure to pay hospitals at higher rates. And it sort of asks the question, well, what's the right amount to pay? And maybe we can start with a break-even amount. And that was sort of from Maryland's work at Nashby as well. So if you go to the next slide, break-even is basically saying, if I take all of the information in there, their payer mix, their bad debt, their charity care, all that stuff, what would a commercial payer have to pay a hospital to break even? No profit, nothing, right? And you can actually calculate that because you have Medicare cost reports. And so if you go to the next slide, Maryland's team has actually done that, which is fabulous. So nationally, the break even is 122% of Medicare. In Washington, it's 153% of Medicare. Now, you remember what we saw, what we're paying for hospitals? Remember 288, 324 on the inpatient side? So it's a little bit, I think we're doing okay. We're paying, that's more than, it seems like a lot of margin. But that's what their cost reports would say is the break even based on what they submit to CMS. Let's look at it a different way. On the next slide, I took a couple of hospitals. These are urban hospitals. They're big hospitals. We're going to call them Hospital A and Hospital B. They have a pretty similar payer mix. You can see that. The purple is Medicare. The green is Medicaid, around 14, 15, 16%. And then the dark blue is commercial. The little sliver, it's the percent of patients that are charity. That's not the percent of what they've paid out in charity. The percent paid out in charity tends to run below 0.5% in general. sometimes 0.1, 0.2, 0.3, somewhere in that range. Bad debt's in there a little bit, so that is what, these seem like pretty similar hospitals. So let's look at Hospital A, and that's the next slide. Hospital A is, it's in a big urban center. Hospital A is taking pretty complex patients. They're getting paid a lot more than that $18,000 that we saw earlier because their patients are more complex. They also have operating expenses that are pretty high. But they also have a margin, and that margin is 25%. Okay, well, maybe they got other expenses that they have to deal with. Direct patient costs are $9,000. They provide some charity care. And then I put that sort of mix in terms of how they distribute their dollars. The first example I showed you was 28% to patient care. These guys put 38%, so much higher, and a lower non-operating expense in there as well. And they made, in 22, 5%. That's pretty good. I think most hospitals would go, God, in 22, if I can make 5%, that's a great deal, right? So they did pretty well. Not sure where the dollars came from. Marilyn's pretty sure she knows where it is, but they made 5%, right? So you'd say, well, that's pretty good. How about Hospital B? Because Hospital B looked kind of the same, right? So Hospital B, also in an urban area, also more complex patient population, higher revenue per discharge. Their margin wasn't quite as high. It was only about 21%. But this hospital only spends 24% of their dollars on the clinical staff in the hospital, right? And they spend 38% on non-clinical. I don't understand why. They also lost money. So are they, we started wanting to understand that a little bit more because it looked like they had the same patient population. They're making margin, yet they're losing money, the other one's making money. So if you go to the next slide, Sage Transparency, if you're not aware of Sage, is a pretty interesting website that you should just, especially those who love data, just go to. So it takes a lot of the work that Marilyn's team has done. It takes the work from Rand, kind of puts them in one place. And what they do is they can also measure how well a hospital is doing in terms of their operating margin by line of business. So this one, you can see a couple of boxes around there. Hospital A, that was that first hospital that made 5% margin, right? They do pretty well in managing their government contracts. They lost a little bit on Medicare, a little bit on Medicaid, made money on Medicare Advantage. So they're operating really efficiently. Hospital B is losing money on those contracts. And then when you look right below that, our numbers show that they're getting about 265, 267% of Medicare. Rand, just to compare that, directionally in the same number. So they're kind of getting paid at a pretty good clip. But when you calculate their break even, Hospital A has a much lower break even because they're more efficient. And so they may have some other income coming in, so you don't have to pay them as much for their break even. Hospital B, wow, 215% of Medicare. That seems like not a bargain. And we paid them more than that, and they still lost money. There's a quality concern in there too, but that's for another conference. Let's go to the next slide. I said I want to look at a couple of less urban hospitals because that might be important. These are big hospitals, but sort of centers, as we saw some of those referral centers in more rural settings, if you will. And because the rural hospitals have a different problem. Their payer mix looks really different. So this one you see, wow, it's almost 75% government payers, right? And they look almost identical, which I thought was, kind of fascinating. They both provide some charity care, kind of like the urban hospitals did. Both are doing a little bit more Medicaid as a percentage than the urban hospitals, 17, 18%. But their commercial, where they can cost shift, is only 26%. So we would expect their costs or their need to shift to be higher, right? If you go to the next slide, did that same graph, a little bit of an eye chart. If you look at Hospital D and you look at how they're managing Medicare, Medicaid, and Medicare Advantage, They look in general a little bit better than Hospital C, although I don't know what's going on with their Medicaid. I don't know how you lose 109% on your operating, side. Commercial, they're both making a lot. They're doing really well, right? Over 60%. When you look at the price that's being paid, we had the same rate as Rand showed, which I thought was, it's not a typo. And so they're getting paid at a pretty high rate, but because Hospital C is a little bit less efficient and maybe has some other expenses in there, their break even is a lot higher. Hospital D looks like the other first hospital we looked at, Hospital A. Looks pretty good. Both have really high quality scores though, so I kind of like that. The efficient hospital broke even in a tough year at 0. So that I thought was sort of interesting. So let's go to the next slide, and I'll stop talking for a little bit, and we'll bring our panelists up. But what we saw in our data is that employers and commercial plans, and when I say the two, it's almost the same thing because it's mostly employers paying, but individuals on ACA plans paying almost threefold what Medicare is paying. If you look at the RAND data, Washington's not the worst. So inpatient-wise, we're the 17th, on the list. So we're not number 1, so that's good. But we're also not number 47 or 48. There seems to be a fair amount of variability in how hospitals are operating. And I think all of us would be happy to send people and pay for a hospital that's efficient and has high quality. I think we would have questions when they're inefficient or have poor quality. And we would maybe want to provide some incentive for them to do something different. You can calculate a break even on all of them because we have that data. And I think the real question, and some of the questions we'll ask our panelists is, how do we get to something that's fair? How do we get to something that really incents, places to work either within a budget, within some other parameter, but the way it's working today does not seem to be getting us what we need. And one way to think about that on the next slide is something that Nashby also put together, which is you can compare the costs, so you can figure out what your break even for those hospitals are. MedPAC basically says that an efficient hospital is in that 120, 130% of Medicare range. So maybe if they're there, whatever that number is, if they're efficient, just pay them a little bit more, pay them a higher margin. If they're inefficient, maybe you don't give them quite as much, but you want them to still be operating to be sustainable. It's when they get to be 2 or 3-fold. There's one Seattle hospital that has a break even over 300%. It's hard to imagine. They're not paid that much, but they seem to still be in business. I think that's where you start looking at national numbers and peer numbers and wondering, what's going on, with that, because we as the purchaser probably shouldn't be paying for all those things. So with that, I get to stop talking, and we're going to bring our panelists up, which I'm more excited about than you having to listen to me. And so we'll just we'll put a little video on while we do that and ask our panelists to come up, and we'll let them introduce themselves and things like that. And we'll take questions at the end, not to worry. So I'm going to ask people to introduce themselves and sort of where they're from, and then I get to ask a bunch of questions. So I'm going to start with Emily at the end.
Okay, all right, thank you. Well, and I have a couple minutes here.
You have a couple minutes.
All right. Hi, everyone. So nice to be here with you this morning, and thank you. That was a fantastic presentation of the data. Really appreciate this report. So I'm Emily Bryce. I'm from Northwest Health Law Advocates. I'm the deputy director there, and we are a nonprofit organization that's focused on getting access to more equitable, more affordable, and more accessible healthcare in Washington State. I'm here on the panel today to talk about how all of that data that we were just talking about impacts people, right? Because we spent a lot of time thinking about, well, how's it looking from a hospital's perspective? And I think it's really important that we also talk about how this is looking from a perspective of Washingtonians here, how it's impacting us. And I think from my perspective, we are on the brink. So consumers have been focused for years on getting access to coverage, getting access to affordable coverage. And we've done that for years and years through subsidies, going to people like Representative Macri in the audience with us today and saying, please help us subsidize this coverage. We can no longer do that, right? We're at the point where we don't have the state budget for it, and we can't buy ourselves out of the problem anymore. The situation has gotten much worse in recent years. So way back in 2022, we did a survey of about 1,300 Washington residents. And what we saw is that half of the people reported to us that half of those people were skipping care that they needed, not taking prescription drugs that they needed because of cost. All right, what's happened since then? Well, premiums have gone up. So we had about an 8% average increase in 2023 for individuals, 9% average in 2024, and we're looking at now 11% average premium increase going into 2025. Of course, that's proposed. We'll see if it holds, but if it does hold, that's about 30% premium increases over 3 years. That's staggering. Where's that money coming from, right? It's coming out of Washingtonians' pockets. And that's before we even get into out-of-pocket costs. We talked a little bit about that, about rising deductibles. And we know from Healthcare Cost Transparency Board data that personal income compared to deductibles, deductibles are rising about 3 times faster than personal income. So again, where's this coming from? Families are digging deeper and deeper and deeper into money that they don't have. Same is true for small businesses. So I'm here representing consumers, but also I work at a small nonprofit. And I'll tell you, those of you who also work at businesses, we're getting ready to look for our insurance renewal for the upcoming year. And I'm frightened that we're not going to be able to make payroll and also pay for the insurance increase that we are undoubtedly going to get. That's not unique to our situation. When you look at the NFIB, for example, National Representative of Small Businesses, they have reported for decades that healthcare costs are their number one concern for small businesses. So I'm really excited because I think we don't have the luxury to look away from this problem anymore. We have granular data that is helping us understand this now, and I think we're ready to move beyond just the discussion of the problem and think about what we can do to help consumers. That was a long introduction.
Good morning, everybody. I'm Sue Birch. I'm the director of the Healthcare Authority here in Washington. We spend about $22 billion a year on our over 3 million covered lives. So not only do we cover about 2 million folks under Medicaid, but we have a big commercial book of business for all of our state employees and school employees. And we also have the public option here in Washington. So we have pretty tremendous purchasing power. I'm a nurse by background with a little business degree mixed in there. But this is a really important topic for the Healthcare Authority because Washington has continued to be a transformer, a pace-setter state. Ever since Obamacare, we've been looking a little more holistically, not just at coverage and access, not just at overhauling service delivery. We've pursued trying to get more uniformity. And Washington has a long history in quality and really has been the Alliance has been a key partner in quality. But I have to tell you, we seem to be losing ground with quality, and we need to really understand all this variation. And so we have a duty, if you will, to look a little bit more broadly, not just with quality, but certainly with cost and what we can do. And I'm hoping Marilyn and others and will lean a little bit into this myth that, oh, it's all the chronic underfunding from those government, from the payer mix, from the government side. It's the prices, and it is not this mythical cost shift that people refer to. We're going to be infusing a lot of money into our safety net assessment program here in Washington, and yet we've been put on notice that our commercial prices are going to continue to go up. This is simply unacceptable. And the Healthcare Cost Board, which is a new initiative of the legislature in the last 3 years, has really been working with everybody, the industry partners, and certainly Emily's group and others, to really understand. We are just on this journey to understand why all this variation, and we have to just continue to really drive towards more of this uniformity. So that, along with really being innovators in value-based purchasing, the way we contract and the way we do things in alignment through the Alliance and the Purchasers Business Group on Healthcare. We work with Boeing, Microsoft, all the large partners, because when you're bulk buying for this many covered lives, obviously you get tremendous purchasing abilities, but we're losing that power, I think, as we're seeing so much shift in the services, and certainly with our plans, we're demanding more. So I think one of the things I want to also say about transformation is this work is so complex, because while we're looking at commercial data today, oftentimes we have reports that look at just the individual market. You heard about the 11% that was reported. And I think the state and the regions and the nation have to continue to look at this, how we are all doing apples to apples comparisons. Because you can distort the numbers and you can push back and create a lot of confusion unless we really all agree to the methodology and the way we're doing data analytics. So we remain in the hunt on really trying to understand quality variation, cost variation, and then service delivery variation. One thing I will say, having come up from Colorado 6 years ago, in Colorado, as Marilyn knows, we were in this work over a decade ago. Washington is unique with very different landscape. We're a highly consolidated market, and I'm going to look forward to the conversation too about how does that data play out when we start looking at the consolidated systems, and what's the cost kind of difference, or where are those costs moving across those systems. The rural frontier areas are a whole different landscape, and so when we talk to our counterparts in Massachusetts, where there's a hospital on every corner, no rural areas, Washington and the western states are uniquely different. And we have to keep that in this discussion, because we don't want to create injury or harm for our rural areas that we are so in need of service area, because they just can't travel 2-3 hours for routine care. So our healthcare authority plays a really unique role in that cost, quality conversation, and then really innovating towards the future. So I look forward to more of this discussion.
Sue, thanks. I think one of the other things that you mentioned about sort of that mix of payers, right? So Medicaid underfunds, right, is the question. Well, when we ran our data, we did a quick look at Medicaid, and we're going to do a deeper dive. We're going to run our report on the Medicaid population as well. The quick hint is it's above 120% of Medicare. I don't know how much higher than that it is, but it's not that they're underfunding, because Medicare is based on, this is what a hospital needs to get to break even, right? So more to come on that. Will.
Hello. Yeah, I've been at Milliman over 30 years, and I've specialized in hospital contract analytics for the last 25 years. And so I'm most interested in, I think the discussion here is on price variation. And it's been so interesting for me over the years, done a lot. We're blessed at Milliman, have a lot of data. I've seen the variation, but it's always been lock and key, guarded very closely. It's very exciting to me now that we have transparency and the data is coming down, although it's really sketchy quality, but improving hopefully. And then, you know, organizations like the Alliance here posting this report and getting more exposure to this. I think it's so important and empowering, especially I think the employers are really key to making this transparency really work. There's a lot of pushback right now, I think, from both the providers and the payers around, we don't want this data out there, or it's good enough, or whatever, and the employers are really the ones that are gonna have to keep pushing. I know Maryland's doing a couple other things around that, the employer empowerment, and I think that's really important. So I hope everybody gets that message and does what you can to push that along, because I think, again, the payers and providers would be happy to bury this. They're already complaining that the costs are high, compliance is high, and the data's still not very good or accurate. Well, let's make it better. You know, Maryland's gonna talk about cost reports, and we were talking about how the hospital's complaining. I think Sue said something this morning on, well, this data, the cost reports aren't trustworthy, and it's like, well, then fix them, you know? Like, put the energy into it. Let's have good data so we can have a good dialogue and really get to figuring out what is the fair price. As you said, we need the hospitals. We all want good hospitals, but do we need them to have, you know, a piano in the lobby and a massage suite, and everybody, every hospital to have a state-of-the-art cancer treatment center, or can we have some focus and some competition where they can specialize on different things? There are ways we can cut costs if we align the incentives, get the prices out there so that people can make good choices and push them to be more cost efficient. So I think this is gonna be a good conversation, a good balance, but Maryland's got some good stuff to add here too.
Marilyn, tell us a little bit about you, and tell us a little bit about NASHB and sort of the work that you've been doing, because I think it's fascinating.
I'm an accountant, so actuary and accountant, we might be the two most boring people on this panel. But having been a controller at a large carrier and a CFO for a regional TPA, I learned how to follow the money. But my journey into where I am now started when I assumed the role of the administrator of the state of Montana Employee Health Plan. And it was projected to be at minus $9 million in 2 years for reserves. So in 2 years, I was challenged to turn that plan around. And I went right to the data because I believe any effort has to be data-driven. Get rid of the rhetoric. Get down to the data. And as the employer, it was my responsibility, my fiduciary role, to make sure that those plan assets were being spent responsibly. So I immediately saw that 43% of our spend were the Montana hospitals. And so I dug into all the data I could find, the Medicare cost reports, the audited financial statements, the 990s, different reports that I could find to come up. And I started building the model that we have greatly enhanced for NASHB. I needed to know when I negotiated with those hospitals what they needed to break even. I needed to know what their organizational structure was. I did organizational charts to see how many for-profit, not-for-profit, disregarded entities. I needed to know, was there cost shifting happening between entities? And so now that I've put everybody to sleep with my boring accounting talk, we ended up negotiating with every Montana hospital to reimburse them as a percentage of Medicare. That way, the Medicare price, and it was the price specific for that hospital. That way, I had control over future increases. Not only was I going to save immediately, but I was not going to be beholden to any insurance company for a discount off a secret charge master number that can change. So in the end, we did other things with pass-through pharmacy. We terminated a lot of point solutions. We did a lot. And when I reported back to the legislature 2 years later, we were at $112 million to the good. So we really did revamp that plan. So I went on to the National Academy of State Health Policy, and our role is supporting states with what they would need. And the Americans are saying, the last poll shows 94% saying their biggest concern are healthcare costs. So my role at NASHB is helping the different groups understand costs, and I've been fortunate from behind the scenes to get to work with Millbank, but I mean, they keep me in the closet. I'm the boring accountant. And so we enhanced the hospital cost tool. We worked with Rice University, Baker Institute of Public Policy Health Economists. We have worked with RAND Health Economists. We've worked with Mathematica Health Economists. I think I need to add an actuary to our team. And we developed the tool to be able to get this data to states to help them better understand. And fortunately, more transparency is coming on board. We're starting to look at those files. And the more transparent we get with data, I think we're going to be able to address these issues. So my role with NASHB is to help with the numbers. Long story.
Tell them about your earrings.
Oh, yes, just to be, I have my debit credit earrings on today.
Okay, that's less boring. And if you add Will, then you won't be the most boring person in the room. So, well, let's start. I'll start with Will. You know, because we brought a bunch of information in terms of data, right? And I remember, you know, as a doc and then going out to talk to docs that, you know, the first question is, you know, first comment is the data's wrong, and my patients are sicker, and you don't know what you're talking about. And those are always good hurdles to try to jump over. I know we've got some network contracting people in the room, and they probably get to do that all the time. But Will, when, you know, the methodology we used, you talked about sort of sketchy quality of data. I know we removed a lot of claims in our file because we couldn't confirm that they were accurate. I mean, I think we had over $3 billion in claims that we said we're pretty solid on it, but talk to us a little bit about why the methodology we chose, and, you know, is it really being able to compare apples to apples? And
Yeah, as Drew said, the big question from every provider is, my patients are sicker, you're not accounting for what's going on here. And so a lot of people, even the RAND report that Drew put up there, you know, they use Medicare as a standardized price to do that. At Milliman, we have essentially a revised and refined Medicare, which is our global RVUs. And it's really important because I think people forget that Medicare is made for an over age 65 and disabled population. They don't have a lot of maternity deliveries. They don't have a lot of babies in there. There's a lot of things that don't happen in a Medicare population. And so the data that they use to create their relative weights and their payment process, there are flaws in terms of accounting for the case mix and severity of the hospitals. And so, like I say, Milliman, for 25 years, we've been working on continuing to refine and improve. What's the best way? How do we account for each claim and each service line within each claim? Like, what are the resources necessary to deliver that care? What's the standardized price? So that then if you have that standardized price, you can then add up all the dollars, divide by the standardized price, and get a comparable, and we convert it into a percent Medicare, as Drew showed in his slides. But I think it is really important that everyone feel comfortable. Our goal there was make sure that we could compare, again, children's hospitals, which don't do hardly any Medicare, academic medical centers, cancer hospitals, all of them within having a detailed enough standardized price that it works. I think it's similar for the technical people out there. I'll go really briefly on this. But if you're familiar in the commercial fee schedule world and Medicare, Medicare creates the RBRVS for physicians, and it's at the detailed HCPCS level. And it does such a great job. Again, you could never compare the average cost per visit for a neurologist versus a primary care doc, but you can compare their average cost per RVU because the RVUs adjust for their case mix and severity. And so we've essentially done the same thing. We originally branded our RVUs as the RBRVS for hospitals to be a detailed fee schedule that accounts for that case mix severity. So anyway, I think the data, you know, we've looked at it, poked and prodded. We've been using it for a long time. A lot of payers have even published relative cost rankings and other things on their sites and use it in their negotiations. So I think it's been poked and prodded and tested. And I was surprised on some of your things. I think there's some big differences the way RAND does their report using true Medicare. Not totally even sure what they do on maternity and newborns and some of the other things there. So it won't always line up.
And in your experience, I think when we kind of pulled out this data and we showed it to you, you didn't bat an eye, you just said, yeah. You just sort of nodded at us. Does it compare accurately to what you see nationally?
Yeah, and we are really lucky. We have about over 80 million lives in our research data set. We get a lot of data, and so we've seen what's in Washington, and no, it aligns with what we've seen there. And also, it isn't, I think what RAND shows different state relativities, and I think they're in the right relationships. So like I said, Washington is high, and it is a good question for us getting into why is it high and what can we do about it. I believe in capitalism and price, that we need to empower the decision makers, whether it is the individual patient or the employer, with better information on price so that we're making a good price and quality decision, and pressuring these hospitals. A lot of these hospitals have board members that are also employer purchasers, and they don't know, is that hospital really cost efficient or not? So I hope this data helps them make better decisions.
Now, you sort of mentioned, the price, but then you said, well, but what does it cost to get to that price? So now I have to turn to Marilyn again and say, tell us a little bit about, because your data is using the CMS cost reports. Can you tell us a little bit about how that data gets there, how accurate it is, how reliable it is, and is there a problem with it or not a problem with it? Because I get confused, so I have to ask people like you.
Certainly. I think the Medicare cost reports are the only public source of hospital costs. And I think that's critical because there's hospital price and there's hospital cost. And so we were looking at what is the cost in relationship to the price. Now, we can go to audited statements, which are for this whole system, but when you get down to the hospital, that is the best source. We looked at 990s, but those can be filed by tax ID number. You can do groups. It can include additional. So we narrowed it down to that. Now, there are instructions, pretty clear instructions of what is to be reported on each line in each figure. Now, is that always followed? Probably not, except I do always like the certification that has to be included. It has to be signed by the CFO or the hospital administrator that all of the information is correct, instructions were followed, and they're in total compliance. So that gives you one level of confidence. We do work with our health economists at Rice and Mathematica to really pull out outliers. We take out those, just like you had said, there's some that you just know are way out there. And when we built the tool, we worked with 2 large health systems, and we worked with 1 large independent hospital. And we shared all of our formulas, we shared what we were doing, and it was good because I learned that I was leaving out the cost of organs for transplants. So we learned, and so this was developed with people that were actually compiling those reports. So I feel that it is the most accurate available to us at this point. Now, I'm hopeful as transparency moves forward, we're starting to compare some with the TIC files with the hospital price files, but I'm hoping as transparency. So I believe that, I believe it's a valid source of information, and I think we've accounted for the outliers the best we can.
As Sue mentioned, there's we're a fairly consolidated part of the country, although I think a lot of parts of the country are pretty consolidated right now. Are we missing some data in there? Like, if you got a holding company or a main office or headquarters or something, I remember we used to always having to pay money to some entity that isn't us, the fee, the 10% or whatever it was. Are we missing some of those costs when we look just at the hospital cost report? That I'm not sure that offers value, but it may be an impact of the consolidation.
What you're going to see in the hospital cost tool is that we will remove the costs that Medicare disapproves that are not related to hospital care. So if there's excessive management allocation, excessive home office allocation, that's going to be geared back. But then when we get into break even, we're going to include all that. And subsidiaries, joint ventures, different entities, investment, unrealized losses is a big issue. You're going to see that in the break even. You're not going to see it in hospital operating, though.
So in 22, that was a big issue, right?
And you
Because
saw that on your graph.
yeah, because the hospital, the investment income or the investments went way down because the stock market tanked, and so that on paper shows up, right, as a loss. And you have to account for it that way. If I was an accountant and not a zoologist, I would have to account for that, right? But then in 23, it should go up again because the stock market went up, right? So we should see an improvement, and we're sort of getting hints of that in, sort of press releases and things like that.
I think that's the frustrating part for me, because I can take a headline. I just did one on we were following Mass General, and we'd look at how they had lost so many billions. And then I looked at one of your hospitals here actually, or one of your systems recorded a $4 billion unrealized loss in 2022, the system. So you've kind of got to dig through that. So at NASHP, we really do focus on that operating.
Yeah,
It excludes that.
gotcha. So Sue, as, sort of, I call you the largest employer, in the state, 700,000 commercial members or somewhere in that range. And you're seeing this high variation. We looked at your data specifically. You didn't skew the data. So you're in what we reported. What do you do with all that variation? Because all those employees want to go to their local hospital. They want to go where they want, right? And yet maybe where they want is maybe not the best place to go, or maybe not the cost-efficient place to go, or because you have the quality and you have the cost issues. What do you do about that?
Well, government, we have a really interesting role because we want to be on this journey of inquiry and understanding. We want to work. I mean, I personally, as a nurse, think that health and human services investments are a good thing for society. I just want them to be fair, and I want them to stop creating some of the injury. We heard a few months ago at the cost board from Noam Levy about medical debt and how medical debt is becoming the new social determinant of health, and that people with employer-sponsored coverage are actually the 105 million nationally that are carrying medical debt are really losing their homes and really struggling. It's really hitting at that livable wage household. So we have a duty to, as government, first off, we have a duty to try to simplify, which government's not good at. So we own that there's a lot of administrative burden that needs to get, we need to continue on that pursuit. Now, that's not all because of the state. That's a lot of federal policy misalignment between state and feds. So we stay committed to that, to try to simplify. We have a huge duty also in this state to try to create the utilities or the data alignment or the necessary infrastructure to make this lean and efficient. And we simply have to keep investing in primary care, and we have to keep building up that resource, because the most expensive place to go are hospitals, inpatient, outpatient. We're monitoring the inpatient to outpatient shift. We've got to keep putting downward pressure on these costs, which I'm really proud of the cost board and the legislature for giving us that movement to look at growth caps. Yeah, that's going to be challenging. But at least we've started on the journey to understand and to really send the message of we got to take this seriously because it's so injurious to families, individuals, families, households, and ultimately to our economy. We know that if Health and Human Services keeps squeezing out all the other necessary components of the state budget, that's going to be a big problem. So this is a pretty tall order. I would argue that Washington also has to get better about public-private partnership. I do know that the health benefits exchanges here in the audience, the Alliance, we have all sorts of partners, especially our other large purchasers. We work on this all the time. We're going to be hearing on the next panels about the primary care movement. And I mean, we're not only investing and leaning in on that work here in Washington, but that's a national movement to really try to reshape things. But I do think we have to be able to kind of walk and chew gum at the same time. And we've got to put that downward pressure on while we are in helping systems do business process transformation and or getting to the heart of why are you so lean? We've got to do more of these learning circles between some of the partners. And I think that, I know you didn't name hospitals today. There shouldn't necessarily be kind of a shaming going on. There should be we're just trying to understand this and we're working together. We need hospitals. They are critical partners. And we know with technology, and we're going to hear later today too about all the therapies that are coming forward, we've got to just really overhaul our medical model in the US. I am really proud too that the state has been willing to journey afar to look at some of the neurocognitive challenges that are coming our way with dementia care and whatnot. We've got to keep shifting the paradigm to keep being proactive about reshaping this industry, working together. So I look forward to when we get the right mix of medical and social spending, and then we get the right kind of infrastructure tools, because right now, at least while I've been here 6 years, we have continued to argue about these kinds of reports, and report after report shows us it's the prices and the variation. And if we could just get everybody to a little more uniformity, if we could just get rid of, that bell curve, get rid of both the ends of the tail, for my boring accountants and actuaries, I think we, and this is the practical nurse in me, we would really make some significant improvements on not just cost, but quality and, spoiler alert, workforce. I know we have some docs that are here and that are going to speak later, but nurses, doctors, healthcare workers, they are kind of sick of all of this. They are feeling it. They don't want to deal with all the, what type of insurance does this have? And the contracts are so different. So I worry that what's really going to crater the system is workforce angst and the moral outrage that is happening as there's more ownership and more consolidation. And so that's something we haven't talked about, but the state has a role in that as well. So just a few comments there to fix.
Just
like
a couple
by
easy
tomorrow.
ones, the softballs. Wow. I do want to go to Emily just because, we were sort of talking about the medical debt and the impact on people. They are purchasers as well. They're consumers. But people, we see it in our data that people were delaying care. People, it appears that that's more common in the more deprived parts of the state. So up to 20% of people have zero claims at all, yet their population risk is higher, so their medical risk is higher, and yet they're not getting care. And so that is always a concern for us. From your standpoint, when you look at sort of the, we're using hospitals as a proxy for cost, but they're sort of half the cost. And it's a fast-growing cost. What do we got to do?
Okay, well, we'll give a +1 to everything Sue said. And I appreciate your focus on thinking again about how this is impacting people. And I think the first thing that we have to do is to have a conversation about the harm that is occurring and recognize that this status quo is not something that people can live with. I'm going to throw out my talking points here for a second and just talk a little bit about a person that I met this morning on the lift ride over here. And I said, I'm meeting, he said, where are you going? I said, well, I'm going to talk to a room full of healthcare leaders in Washington. I did not tell him what it was about. He said, please tell them to do something about affordability. That's the first thing out of his mouth. And he said, I have citizenship here and in Brazil and in Italy, and I've experienced healthcare in all of those places. And I'll tell you that when I'm in Brazil, where he's from originally, I can get a heart bypass surgery, and I don't have to worry about the costs, and I know that the quality will be okay. A lot of other problems in Brazil, he mentioned, but that was his experience. And he said, here, in Washington, I'm afraid to go to the doctor. I don't know what it's going to cost. I'm afraid to go to the hospital. And so that goes to that conversation about when hospitals are looking at their patients and saying, well, it seems like the risk is higher It's a question there to ask ourselves about why patients are riskier coming to the hospital. And maybe it's because they are delaying care, right? They're sicker, they're coming to you sicker, right? They're coming to hospital sicker because they can no longer make it to the hospital unless it's a dire situation. And what responsibility do we have in parsing that out? He also said, well, I did actually have to go to the hospital. Finally, I had to have a surgery recently. And I'll tell you that there were things that I think could have been improved. He said, I didn't want the disposable flip-flops. I don't think that we needed to pay for that, right? There were opportunities to reduce waste that even as a patient, someone who's not in healthcare, he could look around and see, right? And I know that the Alliance has done amazing work to quantify that and show, okay, fine, 30%. Maybe there's some room that we could trim from our system, 30%, even as we are increasing in important areas, as Sue is saying. So I wanted to just relay that because someone who is not in our industry, who can't see all of the complexity that we can see and who isn't digging into all of the data in the way that we are, could clearly see the opportunity for change and the very important need to make that change. To the what do we do? I think the first part of it is that conversation that includes each part of our sector taking a bit of responsibility for it and looking at the share of spending that they are contributing to and not making excuses or pointing fingers, which we so often do. And I'm not pointing fingers at anyone today because we all have a shared responsibility here. But to say, okay, what can I be doing in my sector? What kind of dashboards around affordability can I be adding to my considerations and my goals for the hospital? And to Sue's point, what kind of conversations can we be having together with individual entities, part of our healthcare system, to say, okay, you look like you're having a problem. 658% for outpatient doesn't seem good, right? What's going on there? Let's compare it to, somebody who's doing relatively well. When I was looking through the data, Valley popped out at me, and I don't know whether Valley considers themselves to be doing well or not, but I said, okay, well, they're running about 250% of Medicare, seem to be doing a decent job taking care of their patients. What can we learn from that, right? Are there lessons there that, all right, 250%, I honestly think is too much, but better than 658%, right, for outpatient care. So are there conversations we can have with individual entities? I think the cost board has started that conversation. We really need to continue it. And not too far in the distant future, we need to have a conversation about what we do with outliers, right? We can't always be, we can be collaborative as much as we can be, and we should be. And eventually, we need to have some tools as a state and as a society about how to have a conversation when there has been no improvement year after year after year, and there's an entity that or two that are really having a tough time. I think we also need to have a conversation about consolidation, and that's been mentioned already a couple times. I hear sometimes folks say, well, Washington State is already as consolidated as it's going to get. Not true. Go talk to other states about what they're seeing, and we'll see that we are kind of, I think, somewhere in the middle, right? We have, we still have some diversity to our hospital landscape. I think that's a wonderful thing to be proud of. We have a lot of nonprofit and public hospitals. That's a wonderful thing to be proud of in Washington. We have, though, consolidated over time, right? In the 80s, we had about 10% of consolidated hospitals, and now we're seeing that's almost half, right? And I think it will get worse. We have had a number of spicy conversations in the legislature about that topic, and I think there are a lot of different policy angles that you can go to there, but at the very minimum, we need to at least be talking about what's happening there. We need to have good data to understand the consolidation. We need to be tracking it in different ways. We need to be talking about what consolidation is doing and whether it is contributing to any of those prices that we talked about, because the literature tells us that that is true. And so we need to have a conversation about whether that's happening in Washington and whether that's part of the dynamic. So those are some starting points, but plenty more ideas, of course.
Yeah, and we didn't, when we did our data, we didn't specifically look at consolidation, although we can look at a variety of different facilities that are all related, and there's still a range. I was a little kind of surprised that, some were kind of low and some were, where you might have thought they might show up. But they tended to be more, urban, lower, than more rural was higher. So that was interesting. Let me ask another question. We've been talking about payment, and we pay hospitals, and a lot of this is based on leverage and negotiating, power, et cetera. But when you pay for things for a reason. There's a reason that you have a system in place, and you should be getting something based on the way you decided to pay for it. Now, you may not agree with how we pay for it, but we probably pay for it for a reason, to get something. Does that make sense? So what are we trying to get when we pay some hospitals 600% and some 200%? And then maybe overpaying what their break even is. But we should be getting something in return. So what are we getting for that? I mean, we're paying money. What do we get?
I think what you want to get is good quality.
Sure.
And I think because there's not a lot of transparency to pricing yet and how prices are derived, I think those prices can be set by the hospital at whatever level they want. And let's not forget the middlemen in all of this. I won't call them payers, I'll call them the insurance carriers, because the real payers are you, the employers, and the patients and the members. Because really all the money goes into the system from the taxpayers, the employers, the employees, patients. But I think that there are a lot of little add-ons and lack of transparency going on. So what you're really paying for is maybe a network price that's been determined by not you, but some negotiation between a network and the particular provider facility. We've been going through a lot of the cases. There were just some really good documentation released on a case from California that the judge said the behavior is so egregious here between the provider and the insurance company. This information has to be made public. So it's thousands of pages, but we've been digging through it to try to see, and there's just a lot of money going through the system. That's why I love following the money. A lot of money going through the system, so what are you paying? A negotiated price? But what's in that price? You don't know. Sorry, that's not a good answer.
So I just want to follow up on that, because I want to back up from this concept a little bit too, because I remind you guys that healthcare is only impacting 10%, 10 to 20% of a person's health and well-being. So we can deliver the most perfect healthcare in the world, and we're still not getting at what drives 80 to 90% of that person's health status, where they work, what their socioeconomic status is, the environmental things they're exposed to, the choices they make. And so I want to be careful that while we have a duty to keep working on this healthcare piece, because right now it is killing us, we also at the same time have to bring up our prevention, our primary care efforts. And I want to be really careful too that we don't over-medicalize the well-being social services. I see a lot of heads shaking. Because I know, for example, coming out of COVID, we haven't even brought up behavioral health right now and how that is impacting. I think virtually everybody in this country and world have anxiety and some depression about what is going on globally. So I want to be careful that we have to be able, again, to do both these things. We got to have SWAT target teams working in partnership, because I totally agree with Emily. This isn't just hospitals. They are just the biggest spend right now in the paradigm. But every part of the healthcare continuum needs to be looked at. But we have to put downward pressure. You know, we heard when Obamacare lifted that, oh, this is going to take care of the problem, resolve charity care, and price is going to stabilize. Oh, you put up the public option. Oh, you know, we just have heard time and time again, oh, it's all going to stabilize. It's not stabilizing. We are continuing to see a trend that is unacceptable. And we have to also, in the healthcare space, and again, I say this as a nurse and to all my doctor friends, I don't mean to be insulting, but we have to bring up and own the other commonsensical solutions that have to be invested in to improve. Dental care is a perfect example. Like less than 30% of all of us, whatever our pay source is, get dental care. We have such issues with people getting dental care for whatever reasons, access, fear, cost. But we also have issues about non-fluoridated water systems. I mean, these kinds of conversations have to be reshaped, and we have to move in a different direction about balancing this out. And I give a lot of credit to our legislature who's been willing, and I look forward to when the cost board, along with the other 8 driving states in the country, put up this right index of medical to social spend. We know from the other OECD nations, they spend 2/3 on social and 1/3 on health, and they have better health outcomes, and they have better value. And we have to aspire to that sort of transformational thinking. It's going to be hard to do because healthcare is such a big part of our economy, so we can't just crater things. We don't want to just decimate hospitals. We've got to do this in tandem, and I truly believe our hospital partners want this shift as well. They're not real thrilled with all of the fentanyl and all of the behavioral health things and all their challenges. So we got to create a different paradigm for the conversation, and I also want to do a shout out to the employers that have engaged in these conversations because, again, I think oftentimes people do, hey, Sue, what's government going to do to fix this? This is a public-private issue, and we have to do this work in tandem in a different way.
Yeah, you don't want it to get so bad that government has to fix it, because then you may get something you didn't really want. I think I love the comments about dental care, because I always just remember my stat of if people get their teeth cleaned and they're pregnant, their premature delivery rate is half. Yep. We talk about, you know, infant mortality and all those things. I mean, it's a simple one. If you have diabetes, your admission rate goes down 40%. Right? If you have heart disease, your admissions for stroke and heart attacks go down about the same percent. So that's just dental care. And you're going like, really? Well, because it causes inflammation and, you know, all that other. That's pretty simple stuff. It's not very expensive, but it's pretty interesting. Go ahead, Will.
So I do want to go back to your original question of like, how do we use the information of one hospital getting paid 600%, one 200%, and getting that information out there. Just make a simple example, you know, so then you've got an MRI that is $1,000 at the 200% hospital and $3,000 at the 600% hospital. We all don't know that before we make that choice. You may still choose the more expensive one for whatever reason, but one of the things that's really important, so, and this gets into the cost sharing and other things, and so Emily, you know, interested in your thoughts here. I do think it's hard because that becomes into the medical debt as you incent people, even if they're paying 10% or 20%, but letting them know that difference is there. Or we use better HSAs and HRAs so that it isn't totally their money, but it is their money if they can save it. There are ways that we can incent people and get that information out there and hopefully still not make them go bankrupt or not be able to afford a home or whatever it is. But we have to get that information out there. And we have to align the incentives. Because if they don't have an incentive, if everything costs the same, and that's why I worry about Brazil or other countries, we talk about that, if like everybody just can go wherever and it doesn't matter, that's not a good solution either. So I hope we do find ways to. And also, I want to reward the low-cost hospitals. You talked about Valley. Like, I think we don't do enough that the lower-cost hospitals get steered more patients, and we're pushing them there. So it's always about punishing the high costs. I'm like, well, I want to just prop up and reward the low-cost hospitals.
Because you could put in a value-based agreement that says, hey, we want you to lower your costs, and then they get paid less. Yeah. So maybe, yeah, you can lower the overall cost, and you keep getting paid the same. That would be a way to
or if they can get
reward
more volume.
the efficient ones, or they get a little bit more. Yeah, my bias is that, you know, if we could just put everyone on a budget, they would follow the budget, and they would follow the money, but you know, that's in a different lifetime, I think, or maybe I gotta go to Brazil, right?
Apparently,
Okay.
right, that's where we gotta go. So just to add to that, so I would say, Yes, and. So the transparency is critical, and also it is very difficult for individual purchasers and individual people to be able to make those decisions with the information that they have. And we've seen that through all the state's great efforts to make data available. There's a transparency website. When we think about this data that we see today, is that something that you could actually use to make a decision about where you'd go for your hospital care? I couldn't. I'm in this industry, right? I understand a lot more about healthcare than maybe your average person. And no matter how much you try to overlay cost and quality information for consumers with referral patterns and following your doctor's recommendations, people go where they're told, or they go where they can go, and they know that they can go, and it's close to them. And so I think we have to be careful about assuming that that's going to take us all the way there, because it's an overwhelming set of information for people. The literature is very clear that when presented with transparency information, people cannot make decisions with it, and no matter how you try, I think, to make it accessible to people, because they're not experts, and they shouldn't have to be in order to get healthcare that is affordable and accessible. That's our job collectively.
With more hospitals, thank you. More hospitals sort of vertically integrating, where they got every sort of piece of the puzzle. Some people have argued that hospitals should just run their own health plans. We saw that in the 90s, right? I mean, every hospital was kind of lining up to say, I can run a little health plan, and that would be good. Then they can follow a budget, then all the falls on them, so there's no probably administrative burden when they figure out that they can't, do evidence-based medicine, but that's okay. But should we do that? I mean, should we encourage, the hospital system, especially those consolidated ones, just, hey, stand up a health plan and just run it?
Well, the concern I have about that is you need the commensurate checks and balances to monitor. And quite frankly, again, I go back to, for whatever reasons, our country has not allowed for some of those investments. Again, we're a pretty sophisticated state. We have an all-payer claims database. As you know, we have two, as you know. And we have a health information exchange. We have some of these tools, but they need to be sharpened. But it's not just the tools. We need the teams of staff resources. For example, Massachusetts, who's always 6 years ahead of us on everything with Romney Care turned Obamacare, they've got 120 people that work on this all the time. And look what just happened with Stewart Hospital Systems. I mean, they were absolutely fleeced because that was a land deal with real estate. If those of you haven't been following what happened I see heads shaking. So, you need Department of Justice, you need Department of Labor because of the ERISA part of this. It's not just CMS and Health and Human Services. These components need to come together with state and federal policy alignment. We're really lucky we've got a representative here from the insurance commissioners. We have good alignment in our state. We're doing what we can do, but we need sharp tools and the right teams to really be monitoring these things and being proactive. We have some weak state laws and rules that need to be sharpened, but we need also the political fortitude to cut over into this space where we are going to put downward pressure and say this is unacceptable. And we're going to do things like, I'm just making this up because we haven't decided yet as a cost board, but reference pricing. I mean, our state, I see Dr. Transu there, who was a pioneer on things like bundled payments, centers of excellence. I mean, when I think about the number of value-based purchasing arrangements we have tried, and we've learned a lot. They haven't failed, but it's not good enough. You have to do this system transformation at the same time, and this is slow but important going. We're going to talk in a little bit about those high-cost drugs because, we haven't. I think we had a sidebar conversation, but the GLP-1s, we just costed out the new weight loss drugs $3 billion per year in our state just to kind of go down that. What are we going to do? We need an ethicist on the team for these very complicated decisions about what we're going to do with more of all these therapies as we continue to transform and move on. So this is not it's just not a simple solution, and it's many. I tell everybody there's no silver bullet, it's silver shrapnel, and it really requires working together and really sequencing these right components to keep moving forward.
And I think, Marilyn, it was you talking about not every hospital needs a big cancer center, or not every hospital needs to do spinal fusions or whatever. And I know we see that in some of the actually some of the rural hospitals. You see very complex procedures being done, but it probably, I get concerned just because of volume that the quality may not be there if you're only doing 3 to 10 a year versus an academic medical center that might be doing hundreds. So did you find in any of the states that you've worked with where they started looking at sort of the service mix and being able to adjust that? So you have, kind of the centers of excellence, or just, if you do more of something, you tend to do better, but it's not 100%, but,
That's a very good question. It's something that needs to be addressed, and we've worked with a couple of states that are dealing with this, and where in one state where it boiled to the top was when we did the financial analysis. We couldn't understand at first why this hospital looked so poorly. So we used the data to sit down with the hospital and talk, and they said, well, we've got to cover the losses because of this burn center we're building. And you start to question, how many burn centers do you need in one state? I'm not terribly sure Montana has any. I hate to say that, but maybe that is more centralized, and you transport people to that level of care that is so expensive to maintain. So that fits with what you're saying there, Sue, is that we do need to look at that, and that we've got 2 hospitals in Billings. In fact, they're right next to each other, the 2 campuses. And one always had the great maternity center, now the other one does. One had the great cancer center, now the other one. It's just, can we race to the bottom financially by racing to the top? And now they're fighting over who can be the first tertiary center. So how does that get fixed other than, as Sue is mentioning there, is it a regulation? Is it a regulatory body? I'm really more into open market and competition, but is that not working? And does there have to be some hospital oversight? And I wanted to ask a question, because I really do want to know this answer. When you were talking about how complex all of this is, and the price transparency, which we're working on, is going to get better and better and better. But the comment was made that it's too hard for consumers to be shopping where to go to get the MRI, and it shouldn't be their responsibility. I ask you, whose responsibility is it? I'd like to know that answer.
I think there's a responsibility for everybody to play a part in this, right? It is all of our responsibilities to take a look at the data that we have available to us and try to do your best within, for example, tiered cost sharing to select the providers that are available to you in a lower tier. Same thing for purchaser, right? Purchasers, it is a responsibility to try to do your best by your workers. But I think it's also a shared responsibility, and I kind of come back to that. We can't put it all on purchasers to drive these changes. And I think to the question about what we could be doing for some of the hospitals that are struggling, right? That's real. We know it's real. I think that's a question that I would love to pose to hospitals that are in that situation, right? Because we can't necessarily just be going back and doing a bailout for those hospitals, right? We see time and time again, there are particular hospitals in our state, you were talking about Montana, but the same for Washington. There are hospitals in our state who come back every year and say, I still can't make it, I still can't make it, I still can't make it. At a certain point, you have to have a conversation that says, what do we need to change about your hospital and your situation? How can the state support you in a more sustainable way? How can we change something with respect to Medicare, et cetera? How can we be working on an innovation waiver for you? To how can we be thinking about your services, to your point, that gets you out of that hole? Because there are certain hospitals in our state that are kind of in that perpetual situation, and where the state has kind of put something out. So for example, I know there was a chart effort several years back that ultimately didn't go anywhere. Maybe that wasn't the perfect model, but can we do more of thinking about those transformation opportunities to get us to a different outcome? So I took us a little bit from where you were going, Marilyn, and people might want to weigh in on your question.
Well, let me ask, and then I'll stop asking questions. From an employer standpoint, maybe not a big employer, but an employer standpoint, does an employer have a role here? Can they do anything within their plans? And if so, what should they be, thinking about and/or doing with their, especially the self-insured, in terms of their plan designs and others?
Well, I'll jump in and I'll say, one, I think Maryland's doing some good things around the employers getting the data, getting their own claims data, being aware of some of these price variations. But I think pushing the payers, the insurance companies, whoever their TPA is, we need apps. I mean, the whole world is in an app, and sometimes this gets overdone. But I do think healthcare, as complicated as it is, I don't really want to spend too much time here, but I think we've done a lot of things where, if you really could go in with your doctor and your doctor says you need to go get this MRI, and your app could pull up and you could say, okay, here's where it costs, or I'm going to go get this surgery, and then it's going to get to, Emily, you hit to some of these, you're going to the surgeon, but what's the anesthesiologist? What facility are they admitting at? All those things go with that decision, and it should all be rolled up together so that you're looking at the one price. I'm going to go see the surgeon. Well, that means I'm going to go have it at this place, and I'm going to get all these other things done. This, app wouldn't be, we got a lot more complicated things going on out there. This would be complicated. Now, we can streamline some of our fee schedules and contracting to make these apps and comparisons easier too. There's definitely complications, but we have to get to a point where people can make that decision with their doctor of, okay, I'd like to go here, and they're like, no, don't go there. Yeah, it's cheaper, but don't go there, or whatever. But we don't have that information in real time where you can have that conversation with your doctor.
That's a really good point. I think that app, and then you could make that decision, but you're going to have to work, as you said, with all the players, because let's talk about networks, and let's talk about referral patterns within hospitals. Are they sending you to their own specialty person? So there comes a lot of things that you had mentioned that have to be unraveled, because I love that idea, is that, okay, where's the best place? I can just go there, it's going to fit. It's out of network, it's not in the Blues plans. And so there's a lot of roadblocks.
And that's what I worry about, getting hospitals to create their own insurance company. Like, they just don't have the resources. Let's go back, to me, capitalism, division of labor, specialization, let people focus on something small enough they can do a good job and make the transfers between organizations work well.
Yeah, we have one of our alliance members who happens to be a hospital. And so they sort of started doing that with their own employee plan. And they wanted to make sure people were going to the best quality and best cost. They also employ a bunch of subspecialties. Some of those were not the best quality and the best cost. They excluded them from the plan because for their employees, they wanted the best. I know we've been talking for a long time, and I'm sure there's people in the audience that have burning questions that they want to ask. But any of the panel have questions for other people on the panel before we open it up for everybody else? No. So are there any questions? There's a lovely microphone there that we ask you to speak into it, because that way the people online can hear stuff. There we go. And then please say who you are and all that kind of good stuff.
And affordability in Washington State. had the Alliance reached out to WISHA or any of its hospital members, I'm sure we would have gladly assisted with developing a methodologically sound report. Unfortunately, this report has many flaws, some of which Will mentioned, and my colleague here, Andrew, will enumerate some of them. I will note that we don't actually have a problem with using Medicare cost reports. We think that's accurate, but they do need to be used correctly. That said, we strongly agree with the Alliance's stated goal of paying hospitals for the actual cost of providing care plus a reasonable profit margin. In 2022, the year of the data used in the report, Washington hospitals had a negative 10% profit margin and a negative 7% operating margin. I think we can all agree that is not the cost of care plus a reasonable margin. Further, the report assumes that Medicare is an appropriate and sustainable payment rate, and several of you kind of made comments to that effect. But a recent report from HCA's consultants, Bartholomew and Nash, to the Healthcare Cost Board noted that Medicare rates only cover 83% of the cost of care in Washington state. So I'm really curious to hear about this Medicaid study that you mentioned is coming down the line. So again, I would just say, WISHA welcomes the opportunity to collaborate with the Alliance on their upcoming proposed next steps of analyzing rising staffing costs in hospitals, Washington's robust and newly expanded charity care law, and also actually achieving that fair price equation that is discussed in the report. So I'll turn to Andrew to discuss the methodology a little bit more.
My name is Andrew Boos. I'm the Policy Director of Finance with the Hospital Association. I've been there a while, but I've spent the bulk of my career actually on the health plan payer side, negotiating contracts with hospitals for Medicare, Medicaid, and commercial products. So I kind of understand how the methodologies work. My academic background is economics with an emphasis on statistics and research design. So I'm not an actuary, but I think there are some kind of low-level presumptions in the methodology that have created concerns for us. I guess I would begin in terms of the all-payer claims database. We agree it's good. We're good to have it, but because of its voluntary nature, it underrepresents, I guess you might say, the larger self-funded groups. I think that skews the numbers in terms of the denominator, in terms of what's being analyzed. And then talking about Medicare, and according to the methodology statement, that it's based upon the base, essentially standard national DRG rate without any adjustment for things such as teaching costs, wage index, which is of course a huge issue in our state, as well as other factors that go into the actual Medicare rates. And so we feel that actually suppresses the number down from what is the number that the hospitals are actually being paid, which magnifies the difference between the two. And then the comparison regarding children's hospitals and critical access hospitals, both of them are paid by Medicare on a basis of cost rather than a DRG basis. And I think that inflames the level of the magnitude of the difference on that. So I appreciate Drew's comment that this is directional, but these are being presented as actual numbers. And I think as we look in terms of working together on what is a fair rate, I think we would ask that we be involved in terms of coming to a consensus on what are the right numbers and right ways of measuring these things going forward. Thanks.
Well, thanks for the comments from the Hospital Association. Certainly as members of the Alliance, you're welcome to be on any of our committees that look at these things. I think the Health Economics Committee would be a good one. So I'd encourage you to join that, because that's where we sort of talk about some of these numbers and some of the methodology and things that we're doing. So, feel free to sign up, and we'll get you engaged that way. I would also say that having been at a teaching hospital, commercial plans don't pay for teaching hospitals. That's a Medicare GME funding. It's also a very small percent of of what a hospital gets. Most of the teaching hospitals, not the big academic medical centers. So I don't think that any of the employers have signed up to pay for GME. I think they do it because those hospitals tend to get paid a little bit more, but it's not really, they don't have a commitment or to do that. I think it's important, having been in a GME program, but any comments from this group? Yeah, go ahead.
May I add something? So first of all, thank you for coming and thank you for engaging in this conversation. I think it's really important. It's the first step. I might kind of pose a question back, which is could WISHA or could any member hospitals consider doing their own version of this report and taking a look at the data from your, I've heard concerns about the data here. I've heard concerns about the data at the Healthcare Cost Transparency Board. Of course, there's a lag in all data sources that are available to us. I wish that weren't the case, but it is the case. And so I'm wondering from your perspective, what does price variation look like, and what are the conversations that you're having within your own membership about that? Because I think there are fertile lessons for us to learn there, and would love to be, in the same way that there's an interest in kind of being a part of this dialogue, would love to be part of that dialogue as well, right? When you're talking with your own membership, I think that would be really helpful for all of us to learn from.
Thank you. My name is Ingrid Ulrey. I'm the CEO of the Health Benefit Exchange. I use she, her pronouns. Pleased to serve on the board of the Alliance. And thank you so much. I learned a ton, especially from you two and your technical expertise. I just want to bring this home to some important opening comments that you, Sue, and Emily made. Sue, you eloquently point out this is a difficult and complex road that we're working to go down to create downward pressure on healthcare prices. And Emily, I heard you pointing out, especially in reference to our market, the individual market, we can't subsidize our way out of this. Both are true. I want to have a note of caution that we don't rip off the Band-Aid of subsidies before we make more progress. Very concerned at the federal level, the ARPA enhanced level subsidies from the feds are incredibly effective right now on buffering those ever-increasing premiums that you outlined. If they do expire at the end of 25, we're in real trouble. And actuaries estimate that 55,000 people in the state of Washington would lose coverage through our individual market. So a sense of urgency. So to your point, Sue, it's long, it's difficult, it's complex, but we have to act now. Washingtonians can't wait. So any final comment from the panel, how can we make some quick and real progress in reducing the price increases? Thank you.
So Ingrid and I get to work together all the time because I sit too on her board, and this is a really significant concern, just writ large. And so I would say to my commercial partners, we ought to inspire folks like the Alliance and PBGH to think about what we could do to create our version of a rate-setting review board for the commercial side of things. I mean, it would be really interesting to say, couldn't we voluntarily come together to kind of share? Wouldn't it be phenomenal if we could agree that we're going to lock at that number? Maybe we can't bring it down, but how do we prevent it in the future from continuing to trend in the wrong direction? And so I do think that there's real interest in what more we can do. I think the other thing that would be phenomenal, what if we all collectively agreed to some redistribution? I believe it's about 80% of primary care is now owned by the health systems. And what if we agreed, let's voluntarily shift more into primary care and prevention? And we don't want to keep saying we need more money. I know my legislature partners over there going, please bring that in. That's not going to happen. But what if we agreed that we've got to start living under the dollars that are out there now? And, we have interesting reference pricing going on in certain segments. For example, with our federally qualified health centers. The feds set some floors about administrative salaries. What if we started saying, we won't allow kind of the CEO salaries to exceed a certain ratio? Because it's shocking to me, and again, this is my nurse bias, but that direct caregivers have such income inequality within the healthcare sector. We've got to look at these sort of more regulatory tools, but do it in a partnership way to look at real solutions. And I don't know where the Healthcare Cost Board will land, because we are studying many of these different solutions. We haven't come to that agreement. We're working in partnership, but we've got to move with speed, because we will, in my opinion, move towards either federal or state solutions that would be more injurious if they're done unilaterally than if we do this in partnership.
And I know we're kind of running up on time, right? And I know there's more questions, and I apologize, but I'm going to bring Stretch up to give us a stretch break. Appreciate the interest, and I love the panel. Thank you so much for helping us out. And I think we've got additional, I love the idea of let's talk about what's a reference price or a set price. Hospital Association, you should join us for that. And we can use that data to come up with something that's fair.
And I just want to add congratulations and thank you. You've taken a big step here as the Washington Alliance to get this conversation going and get some facts and some data out there. Congratulations.
Well, thank you. With that, we're going to take a little break, but before that, just because you've been sitting forever, Ty is going to lead us in a 1 minute or less, even less, stretch break.
Yeah, thank you. I'm not quite sure how I got nominated for this. Denise, thank you so much. Probably the last person that should be leading stretch, but hey, let's have some fun with it. So let's just start with just high morning stretch with our hands up high. Nice stretch. Hold it there for a minute. Yeah. All right, and then my favorite one, because I have a really bad lower back, I like to just call it dead man hang, and I just let my hands hang as low as I can, all the way to the floor. Get your hammies, your back. Oh, yeah, that's great. And then we'll end with one more high morning stretch. We'll just say, yay. All right. Take a good break. How long are we? That's good. Like 5 minutes? How long's our break? How much time do we have? Well, we got about 10 minutes. All right, 10-minute break, network. See your folks in the back. Talk to you.
SIBA Health is a virtual care platform. We reverse chronic disease with the use of personalized medical care, advanced lab work, and digital therapeutics. SIBA Health is a virtual care platform. We reverse chronic disease with the use of personalized medical care, advanced lab work, and digital therapeutics. Patients love SIBA Health because everybody at the end of the day really wants to understand why they are suffering from a certain issue. Most patients go to their medical doctors and they get a prescription, or they have 10 minutes of speaking to their physician. They may or may not feel heard. They go home with the medication, and they really don't understand why they have the issue in the first place. Every year the condition gets worse and you end up with another medication. So here at SIBA Health, we're really in the business of getting to the root cause of the issue. So we help people to understand really what is keeping that condition stuck, or what created it in the first place. During the course of their journey, patients come away from the program with a solid plan on how to reverse their chronic disease and how to make those results stick for the long term.
It's great to see all of you connecting. We need to come back together in the room and go to the next part of our program. So if we can all come together and return to your seats. We're going to get started. We have folks online who are ready to go. If you've been standing in the back, we have a table up here that's completely empty. So if people are looking for a place to sit, we still have seating up front. So we're going to be talking about cell and gene therapy. Our next section, we could have everyone quiet and our speakers come on up. We do have a brief video that we'd like to show.
From cell therapy to robotic surgery, we're leading the way in healthcare, harnessing our strength in both medtech and innovative medicine to drive progress across the full spectrum of healthcare solutions. We're building a world where complex diseases are prevented, treated, and cured, and where solutions are personal. Every day, we profoundly impact health for humanity. We are Johnson & Johnson.
Thank you. So I'm Denise Giambalvo, Director of Member Engagement and Business Strategy at the Alliance. Happy to be here with everyone today. It was a fabulous morning so far, talking about hospital price transparency and where do we go next. But as we ask the question, if we spend more, do we get better? We thought it was really appropriate to have a panel to talk about cell and gene therapy. Many advancements going on. We'll hear about how much is in the pipeline, and most importantly, how do we pay for this, which has been a question we've been asking for over a decade now, right? How do we afford to do this? So I'm really happy to introduce Victoria Alegria. She's with Johnson & Johnson, and I'll let Victoria give you her background, but she'll kick this off.
Hi, everyone. Thank you so much, and it's a pleasure to be here today with all of you. So just a little bit of background so you understand my perspective of things is I am by trade a nurse practitioner where I worked in a clinical setting and started doing CAR T back in 2019. So a lot of this is actually based on kind of my personal perspective and clinical experience as well. So we'll go ahead and start talking about cell and gene therapy. Oh, they told me they were going to do it. Oh, Teresa told me they were going to do it. All right. Okay. All right, so just on the agenda, we're going to define cellular and gene therapies. And I'm just going to say on the simplest form that cellular therapies are when we use genetic modification to cure a disease or to treat a disease. And gene therapies are when we insert cells into an individual in order to treat or cure the disease. We're also going to discuss a little more specifically chimeric antigen receptor T cell therapy, CAR T, and we're going to discuss the clinical benefits and potential patient impact of these therapies. So gene therapy uses DNA or RNA to treat, cure, or prevent human diseases. It is intended to deliver a functional gene that serves as a proxy for the missing or defective gene. And they are being studied to treat monogenic diseases, that is a single genetic inherited disorder, as well as some types of cancers, heart failure, and neurodegenerative disorders. Now, there are certain ways that these therapies are given to patients. Cells ex vivo are isolated from the patient and genetically modified outside of the body and then reintroduced into the patient in order to treat the disease. This is typically what we see with CAR T cell therapy. And then there's in vivo gene therapy, which delivers therapeutic gene directly into the patient. Now, overall, there's currently 37 gene therapies, cellular and gene therapies that are approved. Now, around approximately 8 of them are some of the old therapies, the cord blood that have been around for decades. What we're really discussing is the new revolutionary therapies that are coming about, that are here, that are really changing how patients are treated. So there are certain technologies that are used for these therapies. One of the ones that I'm actually very familiar with is viral vectors. So it leverages the ability of viruses to deliver genetic material into human cells. We all know viruses are really good at getting into cells and making us sick, right? Everybody learned that through COVID, whether you were medical or not. And however, we take these viruses and we modify them so they are no longer pathogenic. And then they are used as vectors for the therapeutic gene delivery into the cells. We also have patient-derived cellular gene therapy products where the cells, again, are removed from the patient, genetically modified, oftentimes using those viral vectors, and returned back into the patient. So CAR T, I'll say that there is currently 6 CAR T cell therapies that are approved, and these are for specific hematological malignancies, including leukemia, lymphoma, and multiple myeloma. Now, just to be clear, if there's any question, I focus more on multiple myeloma. I have just in my career, so that is the one I am more familiar with. But chimeric antigen receptors are synthetic receptors that enable T cells to recognize and bind to a specific antigen on the surface of tumor cells. Well, what are T cells? T cells are a big part of our immune system. They consider them, let's think of them as tanks of the immune system. They circulate around in the body. They are looking for cancer cells. Now, sometimes those cancer cells are able to evade our immune system, and that's when cancer starts to really take off. So these receptors can be introduced into the patient's own T cells by genetic engineering, allowing the modified patient T cells to recognize and destroy tumor cells that would normally evade detection. Essentially, we take those T cells, those tanks, we make them even better, and then we put them back in. CAR T cell therapies have been approved for use in some types of hematological malignancies, are currently in development for a variety of diseases and illnesses. So we are starting to see this expand over time. We're starting to see something new that just came out, tumor-infiltrating lymphocyte for melanoma. That has just recently started. We're starting to see this even fall into solid tumors, not just blood cancers. And here's just a little depiction to bring it home a little bit for you. You have a tumor cell. There's receptors on the outside of those cells. We take the T cell. We genetically modify it using the viral vectors. It is then able to recognize that T cell and cause a cytokine release, which then causes tumor cell death. Now, this is where the process really begins. This is how the technology looks and works, and it is a process. So we often think of treatments for cancers as they go in, they get an infusion, or they get their prescription of pills. This is a lot different. So the first step in this process is the patient's white blood cells are collected. They're then cryopreserved and shipped to the manufacturing facility. They are then thawed, and the T cells are isolated, and then they're engineered with the CAR gene to make the CAR T cells themselves. They're grown and expanded. Now, this part of this process can take anywhere from 4 to 6 weeks, depending on the product. There is a lot of release testing. Everybody has to make sure that this is completely safe. That typically does take a number of days as well. And then they're cryopreserved and shipped back to the infusion center, where the patient then typically undergoes some sort of lymphodepleting chemotherapy for several days, which allows their bone marrow to be able to, in turn, accept those CAR T cells back. So this process, I talked about 4 to 6 weeks or 2 to 4 weeks, anywhere in there. This could take months for this to happen, from the patient being referred to the academic center if they're not already at one, and really start to go through this process. But at the same time, we hope that this long process also has long benefit. And we also consider it more of a one and done sort of therapy. So again, you see cancer patients going in weekly for their treatment or taking pills, all of which have side effects. So let's just take this in consideration of an employer. your employee has to take off every Friday to go get their treatment, and then they have to recover over the weekend. They have those certain times where they're just having side effects from medications and have to take time off. Or even the caregivers of these patients have to take the time off to go and take care of their loved ones or family members. In this process, there is a lot up front, but again, hoping that a lot of these visits and side effects from the other types of medications that are out there just is really eradicated. So another way to kind of look at this, all hospitals are not FACT accredited. They cannot give cellular therapies. So if somebody is being seen in the community, they do have to be deemed eligible by their provider, referred to one of these centers where they are then seen by the provider there. The patient then can undergo the apheresis if deemed eligible, the manufacturing portion, which we talked about. We talked about the lymphodepletion for several days, and then they get the infusion. Now, there's a couple things in here. The follow-up care, oftentimes with these therapies, patients do have to stay within about 30 days of that site, just because of potential side effects. They can then return back to their local provider if they are not affiliated with an academic center, and just follow up normal care as far as blood results and such. Oftentimes during that 30 days as well, they do need a caregiver, which family member, spouse, whomever it may be. Again, a lot of upfront for big benefit later on. Now, I do also want to mention one thing that is happening, and it's really great to see, is some of the larger academic centers, because they have the infrastructure, are being able to do this outpatient now. So patients are not having to stay in the hospital for the 14 days or what have you. And more sites are looking to do that as this does start to grow and expand. Another thing I'll mention too is when CAR T for hematological malignancies started to come out, it was last resort for these patients. There was nothing else left. These patients had had 5, 6 prior lines of therapy. And when I say that, that means that they had multiple drugs, had maybe gone into a remission. They came out of that remission. They had to restart another line of therapy, multiple drugs, and so on and so on. And just imagine, with all of those drugs, there's peripheral neuropathy, there's fatigue, there's diarrhea, there's potential infections, there's a whole host of side effects that can happen. So once this period is done, then there's monitoring that occurs. Typically, patients go back to the academic center here and there for follow-up and just continue to follow up with their local providers. So we talked a lot about a lot up front, but big benefit. So this is a patient that was out there, and you see the pre-CAR T. So all the lit up places, that's all active disease. And you can see that this patient was riddled with disease. So 30 to 60 days later, an additional PET scan was done. Now, just to be clear, the brain and the bladder do kind of light up a little bit. That is normal. That is not disease. But you can see that that disease has melted away. And so these are some of the potential results that we get for these patients. I know that coming up too, in the next segment, it will be discussed about where this is going, how many more of these drugs are in the pipeline, and how this is really expanding and being looked at for all types of diseases. Additionally, and just because I've been asked about this before, we are also starting to see this in other countries. Germany, Austria, Brazil's coming on board, Canada's coming on board in the near future. So this is not just a US thing, and it's getting bigger and bigger. So just looking at the clinical benefits and potential patient impact, may increase survival, decrease morbidity, and in some cases halt disease progression entirely by addressing and correcting underlying genetic cause. I do actually want to go back to something that I didn't complete the sentence on, I apologize. We're talking about the lines of therapy. And before, these were for patients that had multiple lines of therapy. Well, as we have seen that these products provide such benefit to patients, now these products are being approved by the FDA for after first or second relapse. So they're being moved up in the line of therapy, which for patients, as far as I'm concerned, and not having to deal with those potential side effects, is amazing. So before, when a product, you had to have 4 prior lines of therapy, meaning a patient had to relapse 4 times. Now, in some instances, they only have to relapse once, and they're able to receive CAR T. May offer quality of life improvements, such as improved function, reduced eliminating pain and suffering, and a psychological sense of well-being. Now, I do just want to share one patient's story. He was kind of a golden child for me, but he was about 35 years old. He had a son that played softball, t-ball. He was the coach. He worked in the oil industry. Very young, vibrant man. He had high-risk multiple myeloma, had to have radiation as well as surgery to his spine in the past, and he had already had 5 lines of therapy. It was not looking good for him. He, in turn, was able to get CAR T-cell therapy, go into a complete remission, tell us that he felt better than he felt in the longest he can remember. He continued to coach his son's softball. He actually got a promotion at work, moved out west for his job, and went back and got another degree. So when we talk about the functionality of these patients, it really can just be life-changing. As far as what they are able to accomplish, they're not on therapy anymore. They're able to just be more functional through work and life, and so are their family members. CAR T can eradicate cancer cells, provide additional options other than standard of care, and may improve quality of life. So I will let Kirby come up, and I'll be available for questions after.
Okay, thank you, Victoria. Oh, okay, got it. So good morning, everyone. Just by way of background, I'm Kirby Yang. I serve as the Chief Clinical Officer for a company called OutcomeRx. And just again, by way of background, let's see, the last 20 years or so, I've been in the specialty pharmacy business, working for the likes of CVS Caremark, which is now part of Aetna. I've also had the pleasure of working for Express Scripts, which is now part of Cigna. All these companies got bought out, and so been with OutcomeRx now for just a year, and I've been following cell and gene-based therapies for about 3 years now. And just by way, before we started, just curious, how many in the audience, before Victoria gave her presentation, are aware of cell and gene-based therapies? Okay, all right, great, thank you. So despite the RX in our name, we have nothing to do with specialty pharmacy. We are not a PBM, so I'm not going to be here pitching you about transparent PBMs and how we're going to save you tons and tons of money while your trend keeps going up. But what we do is, and I like the suggestion of a SWAT team. I never thought we would be considered a SWAT team, but we live, breathe, and eat 24/7 cell and gene-based therapies. We are an insurance company, and we focus on providing what's called reinsurance carve-out for cell and gene-based therapies. So we're the back engine, and we work with a bevy of insurance-related organizations. You can see some of those that are up there. We work with insurers, we work with reinsurance, brokers, carriers, things that are called MGUs, captives, as well as TPA. So we work with all of them. And so we offer essentially a white label solution. What I do is the clinical assessments for all the cell and gene-based therapies. I then work very closely with our underwriting actuarial teams, and we deliver a package. And we make that package available to the members in the insurance side of the business in which we serve. We also work directly with health plans, and regional health plans in particular. So that's our core focus. And what we provide to them is not just a reinsurance carve-out solution, which when you think about it, it's financial risk mitigation, it's balanced book protection, it's what happens in the event that you get one of these claims. And when we talk about one of these claims, I'll get into it, these are not just million-dollar claims, these are multi-million-dollar claims just for the therapy. So in addition, we provide access to authorized treatment centers, sometimes referred to as centers of excellence. We also provide cost management, and that comes in the way of claims review and repricing. And we also are building out patient support services, and we'll get into the tortured journey for patients and, more importantly, or just as importantly, their family and caregivers for those that are diagnosed with rare diseases. The other product that we provide is a cell and gene-based therapy, and so those are which we work directly with manufacturers to provide assurance what happens when the therapy that's provided, cell and gene, doesn't work. There's a treatment failure, or the durability of these therapies come into question. So that's what we do. So with that, we have to take a look at where we've been. And so a wonderful organization called the Alliance for Regenerative Medicine, they spent a lot of time focusing in on cell and gene-based therapies. This was a report generated in 2020. And you can look at where the pipeline is on the left-hand, my left, hand side of the slide here. Heavy in oncology relative to clinical trials. Overwhelming amount of cell and gene-based therapies were focused in oncology. Now keep in mind that most of the oncology focus were cell therapies, not gene therapies. The other therapies right below that, with the exception of hematology, metabolic disorders, neurology, ophthalmology, those are predominantly gene-based therapies. But you can see a lot less clinical trials, but at the end of the day, if you move over to the right-hand side of the slide, a little bit over 1,000 clinical trials all over the world relative to cell and gene-based therapies back in 2020. Half of those trials were here in the US. The forecast was for 18 cell and gene-based therapy approvals by the FDA by 2023. Okay, and an average cost for these therapies, just on therapy cost alone, we're going to be anywhere between $1 million to $5 million. Just again for the therapy. So I want to bring you into where we are today. And some key constituents here, most prominently the FDA as well as payers. And so today, in 2024, there are 37 FDA-approved cell and gene-based therapies. Remember, the forecast was for 18. So we've blown through that by an exponential amount. Remember, there were roughly a little bit more than 1,000 clinical trials all over the world. Well, it's now closer to 4,000. Okay, now keep in mind, I'm not trying to sound like Chicken Little, the sky's falling. That's not the point. This is really a situation where hopefully you'll see some practical solutions that employers can actually deploy today, as well as things that are happening in the future that we need to be prepared for. So in light of everything else that was discussed this morning, add cell and gene and based therapies onto that as well. The FDA forecasted a number of years ago that there's going to be 10 to 20 cell and gene-based therapy approvals per year by 2025. And again, this was forecasted a couple years ago, and as recently as a little bit less than a month ago, I heard Dr. Peter Marks, who heads up the FDA CBER division, pointing out that they are absolutely sticking to that forecast of 10 to 20. And if anything, it will likely be more, and there'll be a revision to that. In response to the pipeline, in response to the approvals, the FDA is one of the few federal agencies that's actually bringing on more headcount. And much of that headcount is going to be directed towards the review and hopefully approval of cell and gene-based therapies. So what are the payers doing relative to cell and gene-based therapies? Well, I mean, all of us have been through this whole notion that when a drug gets approved, pharmacy benefit, medical benefit, let's throw in some utilization tactics, let's look at formulary placement, let's look at step therapy, let's look at preferred networks, on and on and on. Well, you throw all that out when you talk about cell and gene-based therapies, because these are highly personalized therapies. And these are, as Victoria pointed out, mostly one and done. So you want to monitor adherence? There's no monitoring adherence. Get one shot or one administration and you're done, hopefully. So any pharmacy is going to tell you their value proposition is adherence. And step therapy, these are highly personalized therapies based on genetic makeup. Unlike chemically synthesized products that are for small molecules or biologically developed products that are larger molecules, you cannot do step therapy in gene therapy. So they're realizing that these products are going to be covered under the medical benefit. There's no specialty pharmacy play here, not yet. Doesn't mean that the PBMs are not going to try to get into the cell and gene-based therapy market, because they are. But the reality is that there is no specialty pharmacy channel management then from specialty pharmacy to the patient. Products are sent directly to hospitals, specialized hospitals at that, and they can then in turn administer the therapy to the patient. We are aware that a number of employers have decided, since the chance of getting a claim for these therapies is very remote, and for the most part it has been, there's no need to cover it. Well, you already saw the pipeline, you saw the approvals, and it's been insinuated that simply not covering these things are really not a long-term viable option. For the most part, the approvals have been in very rare patient populations, but now we're seeing approvals for much larger patient populations. Hemophilia is one example. Hemophiliacs, sorry? Okay. So hemophiliacs, sickle cell disease, so you have much higher patient populations. Plus, you just have this, and I hate to say tsunami, but increased drug approval or therapy approvals that are coming in. So simply not covering them is not going to work. And then for employers, what can you do relative to mitigating the financial risk as well as balance sheet protection? And just as importantly, how can you really optimize that member or the family experience? Okay, so we move on there from what's going on really at the FDA. And so, as well as clinical trials that are driving all this FDA activity. So manufacturers are targeting rare disease or ultra-rare disease that have largely unmet medical treatment options. So rare disease is defined as less than 200,000 people here in the US with that specific disease. Now, it's given rise to another category called ultra-rare disease, which means less than 50,000 patients or 50,000 people with that specific disease. So what that means is that it's very difficult to run large patient clinical trials, and the clinical trial results have been so astounding that to keep them from the market would, I won't say be unethical, but it's not the right thing to do. And so you have efficacy and safety clinical endpoints that are surrogate markers. And so it's a little different than where we have therapies that are approved under a traditional approval process. These products are approved under what's referred to as an accelerated approval process. And in this case of cell and gene-based therapies, it's run through the CBER, Center for Biologics Evaluation and Research. That's headed by Dr. Peter Marks. Dr. Peter Marks is an incredible individual. He's a brilliant physician. He's also a PhD, so that makes him a doctor. But he's also an oncologist. And he practiced at Brigham and Women's Hospital as well as Yale. And he has made it his personal mission within CBER to approve as many of these products, providing they meet safety and efficacy endpoints, as quickly as possible. And so keep in mind that when the FDA looks at approving or reviewing and approving a product, they're only looking at safety and efficacy. They are not looking at price. So they are aware of the market and what the price points are, but that's not their core focus. The other thing is that FDA can mandate under this accelerated approval process post-approval market follow-up for safety primarily, and these can be up to 15 years. So if a product either doesn't work or it's shown to be not as safe as they saw in clinical trials, that product, the FDA has the ability to withdraw that product from the market. Okay, last but not least, against this backdrop, what's a pay of concern is, again, what's the durability of these clinical, of these cell and gene-based products? They work, there's no question about it, but how durable is that effect going to be? And if you're a payer and you paid a multi-million-dollar claim, you want to make sure that that member or patient in particular are going to get durable clinical efficacy. So in order to address the concerns for clinical durability, there are a number of different models that are out there, but they all do the same thing. What happens if treatment fails? This is where we get into a whole laundry list of different strategies, different approaches, But at the end of the day, it really is meant to reduce financial mitigation if the therapy doesn't work. So there's an outcome-based contracting. There's a thing called therapy warranty. Warranty is like an appliance warranty or a car warranty. But how the claim is reconciled, that's where we get into the many different variations. And then there's financing options, pay over time, and if the therapy doesn't work, then you're free from paying whatever remaining balance to do so. Again, there's a lot of different variations of how to address clinical durability. And so this is a question that you should be asking if you're on the payer side or risk-bearing entity side. Ask your manufacturer if these are available. To what degree are they going to be available? And again, have them walk through different variations and why one would be better for you as an organization versus the other. Okay, so here's where we are specifically to gene therapies. And you can see here blood disorders. We're going to get the first column is disease category, then we're followed by the FDA indication. So a couple things. One is these all have a common thread. And the common thread is that these are all diseases that are caused by genetic mutations. Now the first 7 rows on this are diseases that primarily affect newborns and children, adolescents, and in some cases adults, but it's primarily newborns and children that these diseases impact. The last one is for more older population. It's an inherited retinal disorder. But if you look at just the therapy cost alone, it can range anywhere from $750,000 to one that was launched a few months ago at $4.2 million. And again, that's just therapy cost. And these are wholesale acquisition costs. So the thing that one has to consider is, okay, here's what they cost. What about the cost that may not be covered by insurance? Which leads us into a patient journey. And as importantly, the family journey. So the first part is getting the right diagnosis. So an organization called Minnesota Rare Disease Advisory Council, which is a state legislated developed group and supported group, looked at the population in Minnesota. And based on their research, they identified that it takes up to 8 different clinicians, 7 to 8 years, to make an accurate rare disease diagnosis. Now, newborn screening helps without question, but we're talking about time is of the essence in some of these diseases. If you don't get, in the case of spinal muscular atrophy, a neurodegenerative disease for newborns, their muscles are literally wasting away. And they don't have the ability to stand, they don't have the ability to breathe, it impacts their ability to ingest food. And so typically patients that aren't left untreated don't live past 2 years old. And so in some of these diseases, time is of the essence. You don't have that time. Then the other one is figuring out where to get these treatments in authorized treatment centers. There's a disease called congenital athmia. There's only one center of excellence in the entire country if for that condition, Duke Medical Center. Other diseases have maybe 5 treatment centers, maybe some more. We get to 120 hemophilia treatment centers, so it varies anywhere from 1 to just a bit over 120. So when we talk about a patient journey, there's nothing like this in specialty pharmacy, maybe oncology a little bit, but there's nothing like this in terms of trying to really grasp the total cost of care, not just for the patient, but also for the family. So we're embarking on developing a total cost of care model by specific drug, by specific therapy, and then building in all the other ancillary costs that insurance may or may not cover. The simple things like travel, lodging, food, okay. What about psychosocial support? What about mental support? What about being able to measure productivity away for this family that's not going to be fully at work, either mentally or physically? Taking all that into account and coming up with a cost model. And then once you get an accurate diagnosis and you can identify the authorized treatment center to receive therapy. Then there's a very complex manufacturing process. And that manufacturing process could take 2 or 3 months. So it's not something they pull off the shelf and say, hey, you're ready to go. It's a very complex process, and we spent a lot of time on that. And Victoria mentioned some of the issues, at least with CAR T therapy. They also apply to gene therapies as well. Not all of them, but certainly some of them. So, and it's funny, but administering the therapy is the easiest part of this whole thing. It's usually intravenous infusion, and there you go. Okay, so patient gets a therapy, everything is fine. What happens next? Well, there's all this post-therapy follow-up. And Victoria mentioned 30-day follow-up, and some of these are going to be inpatient hospitalization. And so again, trying to measure and capture what the cost is going to be, so at least you have an idea what it's going to actually cost for a patient and their family. So what can employers do today to pay for these cell and gene-based therapies? One is you can pay cash, and again, it's the cost of therapy and cost of all the follow-up and ancillary care and cost. There are financing payment options, although there hasn't been a lot of traction to these, but nonetheless, it's out there. Many of you, I'm sure, are aware of what's called stop-loss insurance. So stop-loss insurance may or may not cover cell and gene-based therapies. And then last but not least is reinsurance carve-out. So at full transparency, I'm not a registered insurance broker. For those that are you in the risk, employers that are in the risk-bearing business, speak to your broker, speak to your benefits consultant. They can provide you all the information relative to your risk tolerance and what options are available relative to coverage for cell and gene-based therapies. So we have a use case for municipal trust and municipal trust of firefighters and police officers. And they were going through a decision process, whether or not they should opt in for reinsurance for cell and gene-based therapy. And they had a very good qualified broker that walked them through. And ultimately, they chose to buy into the reinsurance carve-out policy. And sure enough, shortly after they signed on to the policy, they had a member whose newborn baby, through newborn screening, indicated that that baby has spinal muscular atrophy. And so again, time is of the essence, and the treatment option suggested for this patient or newborn baby was a $2 million gene therapy. Okay, the outcome here was a very happy outcome. The baby got the medication as quickly as possible. None of this prior authorization nonsense that goes on. So time is of the essence. The baby received the therapy as quickly as possible. What happened to the trust? Well, based on the policy that the trust purchased, there is no out-of-pocket liability to the trust. So needless to say, rather than paying multi-million-dollar claim, they were covered. Also, for the family, in this case, there was no, or there's very minimal out-of-pocket costs for the family. Now, we couldn't address travel. Happened to be in a very good situation where they were very close to a well-established authorized treatment center, which was part of a center of excellence network for the payer. Okay, so there was a good outcome there. So needless to say, the family was very, very grateful. Baby is doing well. Plan is very happy that they opted in. They absolutely, I wouldn't say love their broker, but they did point out that if they had to pay this claim, it would have created significant financial hardship for the trust if they had to pay out the full amount of the claim. Now, speaking of that claim, we got the claim, and it was for over $7 million. Okay, now that was not a lot amount, of course. It was a billed amount. So we ended up paying $2.2 million, which was the coverage policy, and that was the end of that. But think about if they didn't have that reinsurance policy and the financial implications, and let's just say they got a bill for $7 million and said, well, if we pay $5 million, we still save $2 million. I'm not going to get into the nuances on that, but at the end of the day, a very, very happy outcome, and most importantly, the baby is doing well. So this is material that has come out from an organization called NewDigs. NewDigs is a collaborative multi-stakeholder group that was sponsored by Tufts Medical Center. OutcomeRx has been a key part of the group since its inception about 5 years ago. And so you can see there's a link here. And think of this as a employer toolkit for cell and gene-based therapy. And this is taken off the white paper there. So at the end of the day, is the benefits consultant that you're working with, are they giving you accurate, timely information, as well as options relative to cell and gene-based therapy? There's a whole set of nuance in terms of understanding risk tolerance, as well as and a good broker should tell you what solutions are there available in the market. We're not the only ones that are out there doing this. There are other entities as well. So it's really considering all your options. And then successful implementation. There's a lot of moving parts and pieces, unlike anything, again, we've seen relative to specialty pharmaceuticals or PBM stuff. So who in the organization really is going to take charge on this? And we find it's very different people at every different organization. So some considerations. There are 37 approved cell and gene-based therapies. What option is out there that will cover either all or a portion, or some of the ones that are most concerning to you if you're an employer? The breadth and depth of the authorized treatment centers is very important. What happens if you're in a state that doesn't have a treatment center, authorized treatment center, and then you have to go out of state? We know a number of states that don't have, especially in rural areas, again, where they're going to have to incur a significant amount of travel, lodging, food, and other ancillary services, and as well as cost. We talk about stop loss, and there are pros and cons of stop loss, just like there are pros and cons to reinsurance. Stop loss is good, and basically I've heard stop loss, again, I'm not the broker, so I go on the limb and say stop loss is really kind of a one-year solution, because what happens if you have a claim under stop loss is that then goes on to the following year, plan year, of which you're going to likely pay a much higher premium, or it's going to impact your premium. And the other thing is ask your broker on what type of patient support services are available under this plan or under your coverage options. So why we do what we do? We are a business. There's no getting away from that. But we also have a mission, and our mission is making life-saving or life-altering cell and gene-based therapy approvals for those that truly need it. So here's a release through New York Times on May 7th about the first patient that's actually received a commercially available gene therapy for sickle cell disease. And this was straight a quote from the 12-year-old boy. I want to be cured. So we want to make sure that we play our part in making these available for those who really need it. So with that, that's it.
So we have time for questions. I have questions. I'd like to know if you're telling me now. Is my mic working? Okay. I thought you even turned me off. I was like, oh. Do we have questions in the queue? So anyone online with questions? Okay. So then I'm sorry about that. We don't have time for questions. And if you have questions, you can give them to me and we'll get them answered and we'll share them with the whole group. Of course, you can always go directly and ask your questions. But it's nice when you have a question and we can actually share it out with everyone else, because someone else might have the same question for you. Thank you. Wonderful.
SIBA Health's a virtual care platform. We reverse chronic disease with the use of personalized medical care, advanced lab work, and digital therapeutics. Patients love SIBA Health because everybody at the end of the day really wants to understand why they are suffering from a certain issue. Most patients go to their medical doctors and they get a prescription, or they have 10 minutes of speaking to their physician. They may or may not feel heard. They go home with a medication, and they really don't understand why they have the issue in the first place. Every year the condition gets worse and you end up with another medication. So here at SIBA Health, we're really in the business of getting to the root cause of the issue. So we help people to understand really what is keeping that condition stuck, or what created it in the first place. During the course of their journey, patients come away from the program with a solid plan on how to reverse their chronic disease and how to make those results stick for the long term.
I get the pleasure of introducing the last panel, and in particular Jeremy Chrisman from the Vancouver Clinic. You know, as Sue Birch said, earlier, 10% of healthcare really improves the premature death rates. The rest of it's kind of lifestyle and other things. And we feel that it's very important to go farther upstream to start getting people a usual source of care with a primary care doc or provider, is my bias, and make sure you're managing chronic diseases effectively and timely. And with that, I'm going to pass it over to Jeremy. He's going to give some of his thoughts, tell you a little bit about himself, and then we're going to bring a panel up and have more of a discussion.
Fun. Can you hear me? Awesome. I'm going to get a couple of things out of the way first. I'm a recovering introvert, and my wife is a practicing extrovert. So we have two sons, and my 14-year-old is not yet recovering. So we commiserate about our difficulties with things like public speaking. So when I get to do stuff like this, I like to do a quick just video pan of the audience to show him that even a recovering introvert can get up in front of people and talk. So please say hello. All right. Thank you all so much for indulging me in that. So me, why am I up here? So I get to serve on the Health Economics Committee. I highly recommend it for anybody who is interested in the work that WHA is doing. And as part of that, I guess when I'm on Zoom, I'm less shy than I am in person, and I give my opinions freely, and I have some. And so we're going to talk a little bit about my opinions today. And really light on stats. I got a few of them in there. I'm not here to try and convince you with statistics. I'm giving you the opinion of a family medicine doc who has been practicing in group practice in Southwest Washington for 17 years. In that time, I've held most of the primary care leadership positions at Vancouver Clinic, from an assistant medical director of gosh, what was it? It wasn't HR, it was medical director of, I'm going to forget that first title, but essentially I got to do all recruiting and discipline for the entirety of Vancouver Clinic, which at the time was about 200 clinicians. Never take that job. But then I got to do, for the majority of my my career there, I've been medical director for primary care that evolved into primary care and care transformation. And then in March of 2020, I agreed to move from the physician leadership side of our house into the operational side of the house. I joined the C-suite, reporting to our Chief Executive Officer with the title of Chief Transformation Officer. And on the side, I run a little support group for people who have to describe what Chief Transformation Officers do. For me, I have all things population health reporting to me at Vancouver Clinic, and I get to do payer negotiations. How many payers in the audience? Oh, okay, so no friends that I've made in the past. Providers in the audience. Okay, now in my talk, I will talk about primary care clinicians. The Vancouver Clinic, 500 clinicians. The Vancouver Clinic is a provider of healthcare. I am a physician. Our nurse practitioners and PAs are clinicians. Go to Google and look up the movement of clinician/physician from providers. Most of us don't like being called that. Okay, so I struggled with what to call this talk. So these are independent. Okay, cool. So I struggled with what to call this talk. Should we add burden, do less, make more? I think all of those are appropriate, and as we go through my talk, we'll see sort of where I pulled those individual titles out of. So these are my opinions alone. They don't represent Vancouver Clinic. If I could get everybody at Vancouver Clinic to listen to me, it would look a little bit different than it does today. So that being said, next slide. So the other piece is that I intended to sort of talk bullet point by bullet point as we go, and I don't have the same animation cadence, so if this feels a little clunky, I'm sorry. But I'm an FP doc, so I can roll with the punches. I'm highly adaptable. So what am I going to do? I'm going to reestablish that U.S. healthcare is broken. Sue did that already, but repetition is good, and so I'm going to repeat some of the things that we've already talked about. And we are in U.S. healthcare getting less and less while we're paying more and more. That's sort of the definition of decreasing value. And then I'm going to establish that primary care is a solution. Is it the solution? I don't know. It is a solution. But there's some problems with primary care. And I'll talk a little bit about that as well. Don't advance yet. So I went back during my midlife crisis and got an MBA. And since then, I've been a little bit of an economics geek. And so all the numbers for 2022 came out, right? So the largest economies by GDP, those are there. You can Google them pretty quickly. I will repeat it for the people on the phone, but what's the largest economy on the planet? Still the US, actually. Still the US at 25.5 trillion. Next, I heard China. China's in the mid-17s. I think it's approaching 18. The third largest economy on the planet surpassed Japan. Japan's about 4.1. Third largest economy on the planet. I heard it. US healthcare, 4.5 trillion. We are all working in the third largest economy on the planet. Another way to slice those, and I did this about 3 years ago, so for the economists in the room, for our friends who work in finance, I'm sorry if this is not correct anymore, but I used to say that 8 cents out of every dollar that is created on the planet, 8 cents out of every dollar of wealth that is earned on planet Earth is spent on healthcare in the US. That's unsustainable. So next slide. Yeah, so that if I didn't talk about that ahead of time, you all would have had the answers. So we can't stay in this. If we don't start fixing it, it's going to get fixed for us. It's going to soon become, I think, a national security concern because we won't be able to pay for our military spending. Unfortunately, that's sort of the bar of where it becomes critical, right? So next slide. So health, what is health? It's not just the absence of disease. You know, it's spiritual, it's mental, it's physical. I might say it's also financial, because I'm not sure you can have those other things without financial health as well. And the question is, does healthcare lead to health? And the answer is pretty resounding no. What we're focusing on, the care that we're providing, somewhere between 10 to 20% of meaningful healthcare outcomes can be attributed to what we're doing in clinicians' offices. 10% physical, 10% mental, and the rest is all the things that previous groups have talked about. It's the human services side of health and human services. And as we're spending more, are we getting better? And the answer is no, right? Meaningful outcomes, like how long we're gonna live. If we're pregnant and we're delivering a baby, are we gonna live through that? Is our baby gonna live through that? And the answer is we are stagnating or getting worse while we're spending more. So better interventions to improve health, the people who do it better, the countries that do it better. Interestingly enough, they spend on health and human services as a percent of their GDP very close to what we do. It's just backwards. They spend it in the human services side. We spend it on the care delivery side. So next slide. So value is decreasing. So we are stagnating. We are getting worse. We are paying more per unit, consuming more units. And where is this cycle leading us? I cut out my talk about U.S. healthcare as a Giffen good. Does anybody know what a Giffen good is? No? It's a sort of mythical economic construct that as the price of a service goes up, the demand for it goes up. But what is the price of healthcare choking out our ability to spend on? And it's education, it's financial equity, it's all the things that are more powerful drivers of health outcomes. Next slide. So it's not that we're bad at delivering care. We're actually pretty good at it. If I rip up my knee on the slope, I don't ski, by the way, because I don't want to rip up my knee on the slope. I'm going to get great care, and I'm probably going to be back on the slope relatively quickly. No better place on the planet to have my heart attack and stroke and keep me alive, right? You're going to keep me alive with the heavier disease burden. Next slide. It's that we are bad at preventing the need for care. %21 increase in the last decade of people who don't have a usual source of care. Now 100 million. 1 in 3 Americans no longer have a usual source of care. So as we are providing more illness-based care, we're providing less human services, and we need more illness-based care in the future. Price goes up, need for it goes up. It's not a sustainable cycle. Next slide. So one of our retired internists now, I never thought I'd be able to say that, his name's Cyril Dodge, absolute legend at Vancouver Clinic. He would very easily describe to incoming primary care clinicians what it took to be successful. He said, it's just the 3 A's. It's the 3 A's. Affability, you gotta be nice. Availability, you gotta be present. And ability, you just can't be bad. And towards the end of his career, he added in the 4th, which is affordability. So I like to keep that in as we make sort of a transition primary care might be an answer. Next. So, in the context of an underperforming healthcare system, it really behooves us to invest our dollars where they're going to make the most impact. And we know that patients who are utilizing healthcare are less expensive and have better quality scores when they attribute to a primary care physician. Next. So we're seeing some legislative pressures from the federal and state because they've seen the data that if you attribute to a primary care clinician, you are lower cost and higher quality. 100% of Medicare patients in accountable relationships by 2030, and state wants us to spend 12% of our healthcare budget on primary care. It's at 5.1% currently. Next slide. So this is from the Alliance's data. If you don't attribute to a PCP, higher risk adjusted total cost of care, significant dollars, 27 to 55 per member. I always go PMPM. How do we say participant? Thank you. And that's because we have both Medicaid and commercial. That's why the range. Lower quality index. Now, if you don't risk adjust them, they are cheaper currently, but it's just because they're not getting the care that they need, and they're going to be more expensive in the future. And that's 34 to 39% of our population. Next slide. So, no one can see you now, the Millbank Memorial Fund report. I actually didn't know that you were going to be here. Would I put this slide in? These are the 5 issues for facing primary care in the United States. One, 43% of the PCCs we need. I did some math in the background to come up with that number. If anybody really wants to talk about it afterwards, we can. Primary care pipeline is broken. 37% of all physicians begin their training in primary care 5 years after residency. Only 15% are practicing primary care. While we have less than half of the primary care clinicians that we need. We are underinvesting in primary care. So 5.4% was spent in 2012, down to 4.7% in 2021, decreasing amongst all payers, most pronounced in Medicare. If you ask those of us who practice primary care, new technology in our offices over the last decade at least makes our job worse. Doesn't make it better, doesn't make us more efficient, it makes it harder. And research, 0.3% of federal funding goes into primary care delivery. So next slide. I'm just a primary care doc, but I can tell that we don't have enough, we're not making enough, we're not investing enough, we're actively making the job worse. And we're not trying to understand what can make the job better. I don't feel particularly valued by these results. Next. But wait, it gets worse. So current estimates in primary care are based on current practice patterns, which are not optimized. We talked about consolidation in the state of Washington. If a hospital owns my practice, I have to refer. If a patient comes in and they have a tummy ache, I need to send them to GI. I can take care of a tummy ache most of the time, but I'm incentivized to send people through my office as quickly as possible. Hey, you might not even need to come in for that headache. I can just send you over to neurology and make sure you stop by the MRI at the hospital first. Do less, make more. right? If I do less for every patient, I'm going to make more as a primary care clinician. Even with this pressure, though, if you attribute to a primary care clinician, you cost less and have better quality scores. So even though we are not optimized, even though our incentives are misaligned, we're still doing a better job. Next. So where we need to move is along the lines of making care primary. That means not larger panels, means smaller panels per primary care clinician. Now, you can chop that up in different ways because access is a real issue, and I think during the panel we might get into that. But smaller risk-adjusted panels is probably the answer. Better relationships with your primary care clinician, and truly team-based care. Utilization management in the primary care office, in the EHR at the point of order entry. These are the things that are going to lead us to keeping 12% of the healthcare dollar being spent in primary care. Next. So, who knows what the Dartmouth Atlas is? Thank goodness. But because I don't have 100% of folks raising their hand. Claims-based data that tells us and shows variation in healthcare spending across the nation by zip code. And some of that information, when you look into it, the largest driver of the intensity of services, how much of a thing gets done to people in that community, is the number of healthcare clinicians who do that thing. So more cardiac catheterizations, that community probably has more cardiologists. If we want to double, more than double, the amount we spend in primary care in the state of Washington, I humbly suggest that we need to double the number of primary care clinicians. Next slide. Double, maybe. We probably need more than double, but start with double. And in order to pay for that, we need less specialty utilization. And we talked about payers, purchasers, providers, patients, 4 Ps of the healthcare system. And it's not on any one of us, so we talked about this earlier as well. It's on all of us. And if we don't have a multi-pronged approach, we're gonna get what we got. And what we got is a system where patients now think that if they have a tummy ache, they're supposed to see the GI doc, because that's how it's been. That's how they've been trained and educated. So, next. How do we double the number of PCCs, primary care clinicians? Well, we have to take money off the table. It's not all about money until it is. If money's on the mind of our primary care clinicians that they are not being valued for the amount of work they're delivering, they are always going to be looking to change jobs or change states, change locations, change practice patterns. I'm losing more doctors these days to the idea that, well, if I just go and do a direct primary care model, I'm going to do better, right? We have to keep people in, let's call it mainstream medicine. Marketing from the state level. I think there are going to be winners and losers in this because we're not quickly going to change the pipeline. So if we want to double the number of primary care clinicians in the state of Washington, we have to be first to the punch. We have to get out there and tell people we value primary care in the state of Washington, and we have to show how we do. Now, I wonder about, in the state of California, it can be pretty clear. You want more primary care docs? Well, you can give them state income tax breaks. there's got to be some sort of lever we can pull at the tax level to even the playing field. My medical specialty colleagues make 2 to 3 times the amount that I make in primary care. They can afford all of the taxes. They can afford a house in Portland. I can't. So how do we change that? And the culture of medicine is that the primary care clinician is lowest on the totem pole. But we want them to be the captain of the ship. So how do we change that hierarchy? Have to make it the best job in medicine. It's not currently. Next. So I'm a bit of a downer when I talk. And so my boss always tells me, make sure you leave them with hope. So anyway, here we go. Yes, the US healthcare system is broken. And we have a delivery model, even when neglected, lacking optimization, and with all the wrong incentives, we have a delivery model that lowers costs and increases quality. Primary care is an answer. Is it the answer? And I think that's it. Next.
I'll invite our panelists to come up. Jeremy, thank you so much. And I get to put this one. Gave us lots of things to think about. I don't feel that down. I started training 40 years ago, and we were talking about the value of family medicine at the time. That's where I trained in. There were studies from, University of Washington showing the value. There was financial studies showing the value. We continue to show that, and yet we are still where we are today, which I think you've elucidated really well. I'd like the panelists to introduce themselves, and we're really happy to have Chris Kohler here from Millbank, and you saw some of the stats up there, and I'll let you start first, and tell us your name and what your thoughts are.
Okay.
About what Jeremy said.
You're giving me the talking stick here.
You get
All
the
right.
talking stick.
All right.
I'm going to
So-
sit back and...
First of all, I'm Chris Kohler from the Millbank Memorial Fund. I'm a recovering state regulator. Before that, I ran a health plan. Millbank Memorial Fund is a health policy foundation based in New York City. We are committed to improving population health and health equity by working with leaders and decision makers, mostly in state government, like a lot of folks in this room. Thank you, Nicole, Judy, Sue. And for these reasons, we've really landed on primary care for all the things that Jeremy laid out so well in terms of the value of primary care and the reality that if we want to improve, we're spending all this money, our life expectancy is going through the toilet, we have increasing disparities, and it's because of our unbalanced delivery system, all the things that Jeremy stated. So I'm going to take the baton from Jeremy and also try to draw a connection to the first conversation this morning, because I think the work that you guys are doing, led by the Health Alliance and the state with its Healthcare Cost Transparency Board that we're privileged to support, is absolutely fundamental. You've got to shine a light on this stuff to understand where the dollars are going currently, so that people understand how unbalanced the delivery system is. And I hope you guys, as members of the private sector, understand this is being done with your money. It really is your money that's being spent on your behalf, sometimes without you knowing about it, that is creating this. And so don't let them do it, is really the bottom line, because you are, in terms of increasing costs, nervous employees, presenteeism where they're there but not there. It's what's being done with your money. And so I think this idea of first shedding a light on it, opening up the black box, how screwy is it that for half of our population, we know exactly where the money is because Medicare and Medicaid set rates, and that for you guys, we have no clue. And so we're collectively trying to shine a light on it with the work that's being done by you guys, the Healthcare Transparency Board, NASHB's work, our work at Milbank, and you guys insisting on it. In terms of what the dilemma that Jeremy laid out and this message of hope, let me talk a little bit about what we're seeing around how you actually double the number of primary care docs, because he's absolutely right. And the way you do that is that you have got to increase the amount of spending that goes to primary care. Until you reduce the salary gap between specialists and primary care docs, they are going to make an economically rational decision in spite of Jeremy's charms and the charms of the Vancouver Clinic and the emotional rewards of doing primary care, and they're going to go into specialty care. They're going to do ER, they're going to do urgent care, they're going to go into concierge care, they're going to walk away, and fewer people are going to have the usual source of care that we need. That's not, what did he say? It's not about the money until it is about the money. It's about the money. And so we just have to spend more on primary care. That's why the Transparency Board has set up this 12% target. You guys should know the primary care spend if you're self-insured. You should be asking that of your administrators and demanding that they give it to you and then asking them what they're doing to change it. Because it's your money that they are spending. And the reason why they're having a hard time doing it is simply the law of economics. There are large and powerful providers. I've done this. You negotiate insurance rates, and believe me, primary care falls at the bottom. I love them to pieces, but by the time I've given money to the consolidated health systems, to the ER docs, to everybody who's got market power, I've got nothing left over for Jeremy. And we've got to change that. And the only way you change that is with this kind of oversight and you guys getting together to address those, the market inequities. The economists are right. And so what I want to hold out for you in particular is that Washington is a leader in this work. Not all states have set out this notion of primary care spend. They have not set up a target for increasing it. And they don't have a mechanism for achieving it. And this is where I'll take Jeremy's last slide and go with it. And call out specifically the work that's being done in a private-public collaboration around the Primary Care Transformation Initiative that is trying to do three things. It's trying to align payments across payers, because he can't do the right thing if every payer is sending him in a different direction, and our other clinicians here, if they're sending him in different directions. So you've got to stop the madness and send consistent signals. Next thing you got to do is you've got to spend more money in primary care. You've got to redistribute. You've got to create a more balanced delivery system. And the third thing that you do is you've got to help the practices do what has been shown to establish long-standing relationships, to build team-based care, to provide care outside 9 to 5. Those three things: change the way you pay more, and help the practices transform. And you guys are doing that in Washington with this Primary Care Transformation Initiative. We've seen it happen in other places. You've got to get Medicare, Medicaid, and the commercial aligned. When you do that, primary care practices can deliver on what Jeremy's talking about, and you can get more docs, which Jeremy's talking about. And so where I don't want to take up all the time, but where I would encourage you, because this is your money, is that if you are self-insured, join in with the Primary Care Transformation Initiative. It's being led by the Healthcare Authority. They've got a lot of different places. Judy Zerzenthul is here. She's leading this effort. We've got to get the money aligned to get what Jeremy's talking about, and you have a mechanism to do it here. If you're not self-insured, then go talk to your insurer and ask them if they've joined and what they're doing about it, and work through the Washington Health Alliance to support it as it already has. And I think it's really important. What we hear sometimes is, well, I'm not going to put my money out because I don't want to make commitments around my employees and then have them come back and complain to me about the lack of access. That is a self-fulfilling prophecy. If we're stuck there, then it's only going to get, what Jeremy's saying is only worse. We have to act collectively to say, no, we're valuing primary care. We're going to put our money, our benefits, our provider payment reform where our mouth is. If you wait for the supply to happen and then you join in, you will not get there, and your employees will suffer as a result. So you've got to act collectively. We've got to act around these sorts of things to, again, I'll end, pay the practices differently, pay them more, and help the practices deliver on the promise that Jeremy's talking about. And you guys, you got all the tools here. It's really why I like coming to Washington, is because you can make this stuff happen. So thanks for your work, thanks for the leadership, and look forward to hearing from our panelists. Hope that wasn't too long.
That was just fine. And it's true. I mean, we have the ability to make a difference and make some of those changes. I'm going to go to the far end because I know Rodney came all the way down from Bellingham, had a board meeting this morning. Rodney's a family doc, but your practice is a little different than the Vancouver clinic. The Vancouver clinic, multi-specialty, no hospital. Yours is primary care, and then Edwin Carmack can go right after you. He's in more of an integrated model, but also in a smaller town, more rural setting. And I think they have challenges in both. But Rodney, you can introduce yourself and did you agree with what Jeremy said, or?
Yeah. So I'm Rodney Anderson. I'm a family physician, practice up in Bellingham. I love my job. I think being a family physician is the greatest job in the world. There's some interesting data about physicians who wouldn't choose going into healthcare if they could go back in time and do it again. I'd do it again in a heartbeat. So I think it's a privilege to have a job where you get to pour your time and energy and talents into serving other people. So I feel fortunate to be in this role. My background, I grew up in Western Washington. Actually have an undergrad economics degree. Went to medical school at the University of Washington. Actually did management strategic consulting around the U.S. for a couple of years, and then started, that was before medical school. Ironically thought when I left that job, I'm just going to take care of patients the rest of my life and never think about business or economics again, and that's not obviously how it's turned out for me. So started up in Bellingham in 2009, full spectrum family medicine, inpatient, outpatient, OB work, and then started to end up in leadership roles, and just over 5 years ago was asked to take over as the CEO of an organization called Family Care Network. That was 9 months before the pandemic exploded, so horrific timing. I would not advise a big job change right before a global pandemic in healthcare. Family Care Network is a very unique organization. We are primary care family medicine only group. We're up in Whatcom and Skagit County. We take care of over 100,000 patients. We are only family medicine. So I think we're one of the largest independent family medicine groups in the United States that's left. I love the work because we are not beholden to any exterior or interior incentives or agendas. So we as family physicians look at the patient in front of us and decide what's best for you. We don't have specialists we have to feed. We don't have a hospital we have to feed. We don't have anything else. It's just the work we do. So to Jeremy's comment, I actually think primary care is the solution for what ails healthcare in the United States. If you want to make costs more affordable, don't bring on more cardiologists and neurosurgeons into a community. Get more primary care physicians and free them from all the external constraints that primary care physicians often face. So my personal theory is that primary care docs should be leading healthcare and should be owning and operating their own companies so that they are free from many of these sort of peripheral incentives that drive behaviors that are not in the best interests of the patients that we serve. That being said, I feel very optimistic about the future of healthcare. So I think on many fronts, folks are coming to realize this system is broken, but we should change it. And the first step to change is acknowledging there is a problem. And I think it's well understood that there is a problem now. And I think the conversations around shifting more funds towards primary care is the step to create a sustainable, not just high quality, but cost-effective, great patient experience, relationship-driven healthcare system that we like and that we all want. I was driving down here from Bellingham and I called my mom and I said, I'm speaking at this thing, and she said, she has her 50th high school reunion in a couple weeks, so that's her age bracket. She says, you know, I really miss when you could just go to your doctor and get care. Like, you didn't have to see 12 doctors to get your care. You could just go to your doctor and they could give you all your care. And it's like, that's the world that we need to rebuild. We need to shift funds and resources back to primary care. We need to encourage broad scope of care so primary care docs can manage upset tummies and can do joint injections and can remove skin cancers and all the things that we're trained to do. I think that makes the healthcare system better for everybody, particularly the patients who all this ought to be built around to begin with. So I could go on, but I'll get off my soapbox and pass it on to Edwin, so thank you.
Thanks, Rodney. Edwin, you know, also a similar size type town, but you know, in one that also has a hospital and a specialist? And how does that work from a primary care standpoint for you to care for that population that really doesn't have any other place to go?
Yeah, so I'll start by sort of describing the situation I'm in and where I practice, feeling a little outnumbered, but that's okay. I went to the University of Washington, so we have that in common. So that's good. My clinical practice is as a hospitalist, so you can start throwing tomatoes now. But I practice, and I'll sort of echo Jeremy, I'm speaking for myself, I don't speak for Confluence, but I'm part of Confluence Health, which is an integrated system. It's honestly one of the few independents still remaining in the state. We have a hospital in Wenatchee, and Wenatchee has about 50,000 people in our there's a couple little towns right next to each other. But then we serve 4 counties. So we serve basically from I-90 north to the Canadian border, so it's north central Washington. It's about the size of Delaware, and there's about 250,000 people in those 4 counties. So we're kind of a rural hospital where we are. We're mostly the referral and specialty center for our region for what we can provide. But pretty much all of the hospitals that refer to us are critical access hospitals. It's a very rural area. We also have about 13 primary care sites in our system that span those 4 counties, and those are predominantly rural health clinics. I have been practicing as a hospitalist since 2005. I started out in Grand Junction, so near Sioux Birch, and then came to Wenatchee. It doesn't actually take very long in the hospital to realize that care, that once patients have ended up in the hospital, there's a lot that could have happened before that, that either could have kept them out of the hospital, or even if they still needed to be in the hospital, that they were better prepared for what's happening. And as my career progressed, I became a medical director of quality and population health at Confluence. I more recently am sort of operationally over our hospitalists, our geriatricians who are in our SNFs, and then have some involvement with our home health and hospice. So sort of seeing a wide span of things have helped try and improve the, as we're in an ACO and in a Med Advantage plan, trying to work through all of those, make that better, put it that way. So sort of a broad perspective of kind of what it's like sort of at the provider level operating in a health system.
Thanks. I think you bring a different perspective than just a solo practice or just a multi-specialty group. But Chris, you sort of talked about you just got to spend your money in the right place, right? And we talk about, well, we're spending 5% on primary care today, and it should be some number, 12%. My bias is it should be 25%, but I'm biased. But let's say it's 12%. How do we get there? I mean, I think some of the data would say if everyone had a primary care provider, clinician, physician, whatever the definition is, that you would save 6%. Maybe that gets you all the way there, or most of the way there. But that's hard for an employer to say, do I believe that's going to happen? But how do we get that financing? How do we get employers to take that jump?
I'm just a thought leader. I don't answer questions like that. I can't implement or anything like that. No, there is, just like I was describing the chicken and the egg about we're not going to invest until we create the capacity, there is this kabuki dialogue that goes on with health plans and primary care clinicians, and I'm sure your guys or your contracting entities have it, which is primary care docs say, give me the money, give me more money, give me a different way, and I'll show you the results. And the health plans say, give me the results, and I'll show you the money. and the twain shall never meet. I come out on the, you got to give them the money. The reason why the health plans don't want to give them money is because the economists are right. They are stuck in hidden private sector negotiations. And so what you have to do is change that dynamic. You have to address the market power that has resulted in our unbalanced delivery system, and that's getting worse with consolidation. And so unfortunately, the message is that you need the public sector. I say unfortunate because trust in government is not particularly great. I worked for a health plan and then went to work for government, so you don't follow my career path if you want to enjoy reputational. But you're going to need the government to address this issue. And so specifically, where I have seen it is it's not enough just to set a target to say you will, but you have to create the mechanisms for doing that. You control your own rates for Medicaid. That's a rate setting process. It may mean that Rep Macri has to go find some more money, or she's got to take money away from one place to put it. But you are rate setters, your government is rate setters for Medicaid, so that's one place to do. The other place, and I've done this, is in commercial health insurance, where you say to the health plans, we understand that you are stuck between a rock and a hard place, that when you go to emergency room docs, and now private equity has consolidated all of them and is making them pay even more, that you have to fork that money over. And so we're going to say to you, no, you will increase your spend on primary care. And we've done that. I did that in Rhode Island when I was health insurance commissioner. I told the health plans they had to do it. And the health plans said, well, what am I supposed to say to the ER docs? What am I supposed to say to the anesthesiologists? And I say, you tell them that the government told you that you got to spend more on primary care. And so there is a government role for this. This is redistribution because the economists are right. Market power has consequences. And if we want to change it, we've got to change it through our public policy. So specifically, you've got to support efforts to redistribute the money. And I firmly believe, as was said here, you got to put the money out first. You got to insist on results. You can't just sort of say, hey, primary care, here's more money to do fee-for-service medicine. But we know how to do that. We've been doing that with Medicare payment models. We know how to do accountable care organizations. We know that primary care-driven accountable care organizations do better, surprise, surprise, than the ones that are owned by hospitals. We just need we need to support the public sector officials to do what the evidence supports, but there's not always the political will to do it. And so in addition to your conversation with the plans, you've got to support both in Medicaid and I think the hidden one is commercial health insurance regulation. I think if you start directing the health plans, they know the right thing to do. Go talk to a chief medical officer for a health plan. They know that they're spending too much money on the specialists and not enough on primary care, but they can't change it until someone changes the market dynamic. Sorry, I get excited about this stuff. So.
I'm glad you're excited. And I think, primary care docs are probably excited too.
Yeah.
But even if we pay them money, and I'll turn to Jeremy, he mentioned the 4 A's up there, right? So you got to be affable, you got to be there, you've got to have some ability. You also have to be affordable, and that's not something most of us were taught in med school how to be, right? We weren't even taught to be affable. And we weren't really taught to be available. So, but we had some ability. But what do we need to do to sort of, they're going to give you more money. Why? Because you do so much stuff that is outside of the fee-for-service world, right? That you just can't bill for some of that stuff to do population health, to really manage, a panel of patients versus just the person in front of you. What do you have to do to change sort of the culture? Let's say they give you more money, great. What are you going to do with it?
Well, this is going to be highly controversial, but I don't represent Vancouver Clinic, but I don't think I need more money from the payer. I have most subspecialties in my organization. Give me professional capitation. Look at what we spent last year. Give me professional capitation, and then that incentivizes me to make sure it gets done in primary care, maintain my institutional risk sharing with you. You know, I still need to be on the hook for outcomes, right? So do those two things and we'll spend less money, without a doubt. And then what we save, we can reinvest in all of the things. And by all of the things, I mean advanced primary care. And by advanced primary care, I mean our pharmacy-led, disease-specific clinics, hypertension, diabetes. I mean embedding mental health in a coordinated manner with our primary care clinicians such that they have something to, some lever that they can pull to help patients who need it, including with resources when we screen for social determinants of health. Do they have anything at their fingertips to be able to intervene with that information? So social work technicians as well as licensed clinical social workers who can perform psychotherapy. So those are all of the things. We've done it a little bit, again, bass-ackwards in that we built those things, got outcomes, and then used that to drive fee-for-service rates north. Being able to say, you know, our total cost of care is 3% under market, therefore we need additional fee-for-service revenue to offset that. Again, much rather say, give me professional capitation and institutional risk, and we'll knock it out of the park.
And I would assume that that professional capitation, because you do a good job, doesn't go down every year. And we've seen that in some of the, I was a network contractor for a while, unfortunately. And then, but what we saw is as they did better, they got paid less.
Yeah,
so it can't really do that, right?
I will not sign any contract that's a race to the bottom. You know, let's have a reasonable cost trend that might even be flat, but don't pay me less next year because I did better.
There's a phrase, and yes to everything that she's saying. One of the P's up there is the patient, and so I'll kind of stir the pot a little bit here and say, we can't give the patient a free ride in this either. There's a phrase in public health: make the right choice the easy choice. The right choice here is to have an ongoing relationship with a competent clinician who hits the 4 Ps, and patients need to be your employees. That relationship needs to be facilitated. We can do that with benefit design, and there is associated with that. But the principles, there have been experiments, CalPERS has had experiments, that when you make primary care easy and cheap, you get reduced ER admissions, you get that rebalancing, you get more outpatient services, fewer inpatient services. And so think about the role of benefit design, which I realize for employers is really tough in a competitive market and when everybody wants all kinds of choice. But you can give them choice. You let them go wherever they want. I mean, that's sort of PPO models. But think about zero-based primary care visits to a designated source of care. Make them say, he's my dude, she's my dude, and that's my team. That's what I'm going to work with. What can we do to facilitate that?
Edwin or Rodney, in terms of the payment model, you know, one was, you know, hey, I want prospective payment, you know, capitation, whatever we want to call it, cap with incentives, something like that. Would that work for you guys, or do you need something different?
I don't know that my organization would take it right now. I think, you know, there's some risk adversity. I think that, you know, currently we pay primary care providers basically to do more. And I think that's one of the first things that has to change in terms of the pay model, is that we're paying them to take good care of the patients. And that also means that we're paying them to lead the team that's helping take care of the patients, because that has to involve the social worker, the case manager, the pharmacist. Like, a primary care provider can't do it all, and that's shouldn't be the ask. but we should be paying them to lead that team. So I think, however, structuring the pay model needs to get away from, it's not about just like saying, I think, we're going to give primary care more money in the same model that we're currently doing it. What exactly that model looks like, I think, is really more about aligning the incentives, and however that comes about, I would help me in my population health role.
And aligning across payers. Because as long as every payer shows up and says, use my mousetrap, you're stuck.
So one of the struggles, I work with both, we don't have a huge commercial population. We're much more Medicare, Medicaid. But one of the struggles that I have with my role in population health and in quality is that, we get a set of quality measures from each payer. And there's some crosswalk, and I understand why there's some differences because the populations are different, like there's more child and maternity care in some populations than Medicare. But we're not going to focus on, 30 different measures from all the different payers. And then the way that we get the data from our payers is typically Excel spreadsheets. And I don't know what to do with those, quite honestly, because, they're helpful information for me when I sort of look at them and with my operational, administrative people, but in terms of, the providers themselves, clinicians, sorry, I'm working on it. In terms of, I can't take 10 Excel spreadsheets to them. So how does that integrate into our EHR? How do we get there? And we work on that, but it takes resources to do that. So those are just some of the challenges of sort of getting there.
We can aggregate all that data from all the payers together and give you one non-spreadsheet looking thing, and then you only have to have one meeting.
That has 3 measures on it, so we know what to focus on for that year.
Figure out what the most important measures are that you can work on. The last is Rodney, because I think we're up on time.
Is anybody an orthopedic surgeon in the audience before I start talking? No? Okay.
I've seen one.
So you raised the question, what would you do if we were paid more money? I should say, first of all, that I think even as primary care docs, we're paid well. It upsets me when docs complain about income, and in the grand scheme of things, we're paid exceptionally well for the work that we do. Orthopedic surgeons are paid a lot more. I don't know if you all know, but as you go through your medical school training, you pick a specialty. And the folks that end up in primary care are the folks that are not driven by money. And I like those people. They're my colleagues and peers. So I actually don't think we should be paid equivalent to orthopedic surgeons, because I'm pretty happy with my family medicine colleagues for what it's worth. So, but it's important to note that family medicine docs, in my experience, want to take high-quality, cost-effective care of patients, right? That's what they fundamentally want to do. And most of them, when push comes to shove, the concern is not around income and how much they make. The burnout that you see amongst primary care physicians is a lot of it's based around this concept of moral injury, which is we were trained to take really good care of human beings. That's what we want to do. And yet we fight with this system that is not aligned with that. That makes it exceptionally difficult to do what we want to do. It's like what you see in military, right? You raise kids, you tell them don't kill one another and such, and then you go off and join the military and somebody hands you a gun and says, shoot all those people. And it cracks something in your brain, right? That's the moral injury. And if you wonder why folks come back from wars with PTSD and such, that is a huge psychological disconnect and problem. So in medicine, it's not quite the same degree, but we're trying to take really good care of patients, and then we come into this system with all these layers of regulations and requirements, and we can't get our patients the simple medications that they need. We have to fill out prior authorizations and all these hassles, and it drives you bonkers, and it's frustrating as heck. So I actually think if the system was simpler, and honestly, if payers just got out of the way, that would make it easier. Few things upset me as much as payers saying, we've designed a care management program to take care of your patients. And I'm always like, you don't know my patients. Just give us the money, we'll build the care management program. So what we've done organizationally during the last few years, as we've gotten more funding, is we've built ancillary services to meet the needs of our patients. So we have urgent care centers that operate evenings and weekends that give our patients an alternative option to going to the ER, which is an exceptionally expensive way to get care. We've embedded mental health specialists in all of our outpatient clinics and paid for that and such. We have a care management team that supports patients when they transition through cares, and will go do home visits and such. So we have not taken the extra funds and raised clinician salaries. We've built all the resources around supporting patients to get the type of care and type of outcomes that we want that actually save the whole system money. I mean, that's a really important piece here is The reason why we want to spend more money in primary care and increase that from 5% to 12% is not saying that we think the overall healthcare spend is going to go up that 7%. We're simply saying put more money in primary care, and guess where you will save? Everywhere else across the healthcare system. That's the key, right? So yes, anesthesiologists will make less money because less people will have heart attacks and strokes and end up in the hospital needing surgeries and such. So you don't actually even have to negotiate payment rates down for anesthesiologists. There will just be less utilization because we're doing a better job in primary care. So that is what we're advocating for is, and in so much as you all are purchasers of health insurance coverage for employees and such, advocate for that. Advocate for every employee of yours having a primary care provider. We actually, as an organization, a couple years ago, started experimenting with direct primary care. So that was a couple local companies where we said, you pay us essentially a capitated per member per month rate, and we'll provide all the services we provide for that rate. And we built a couple things into that model. One, no copays for primary care visits. So your employees can come see us in our clinics or in our urgent care centers or call the doctor on call or have a telemedicine urgent care visit, and it costs them $0. And they looked at us and said, does that mean our patients are going to come to you all the time? And we said, yeah, but you're just paying us a fixed rate. It's per member per month, so your cost is fixed. And guess what? We'll keep them out of the ER. We'll keep them away from the specialist. We'll keep them out of the MRI scanner and the other things that cost way too much money. And so it's really early in the process. We don't have a ton of data, but that's the theory behind this. And we as primary care providers, I think, are always willing to be held accountable for the things we can control, right? So utilization, referral patterns, these kind of things, hold us accountable for it. We're not saying we want more money with no accountability. We'll take all the accountability. For the things we can manage, we will take all of the accountability for it. So that's the stance here. And I mean, I think that's sort of the message that we ought to be advocating is invest in primary care, not just to make us more money. We don't necessarily need a whole lot more money, but invest in primary care so that we can work, we can expand the services we provide, and we can create a better healthcare experience for patients while saving money everywhere across the board. So.
Yeah. Can't say anything after that. That was fantastic. We're up on time. I think what you heard a little bit was what you pay for is what gets done. So if you pay for high quality patient care that's going to take responsibility and accountability, that's going to manage both the quality and the finances, that's what will get done. If you don't pay for that, well, you're paying for something else, right? And so I want to thank the panelists who are up here. Jeremy, for your thoughts and opinions. I think those were great. Chris, for traveling all the way out here from Millbank, and Rodney and Edwin coming from the hinterlands into Western Washington. Not quite the hinterlands, but you know what I mean. And for everyone else, I know it's been a long day. I think we heard a bunch of things, right? So we heard some information about hospital pricing. We also heard some information about, well, what does it really cost? We don't, that one's a little less transparent. So how do we get to what a fair cost would be, given the wide variability, 5 to 6 time variability between hospitals? That can't all be because you have to pay nurses more. So that piece was a little bit missing. Some things you have to spend a lot on, cell and gene therapies, to get really amazing outcomes. I mean, any clinician who's taking care of someone with sickle cell disease, this is kind of a miracle, And so those types of things are important, but how do you pay for that? And then I think the way, we're finishing here is really talking about, the entry into the healthcare system, really shouldn't be, because you have a disability, an illness, or in pain. It should be because you're getting a usual source of care, you're establishing a relationship, you're managing what you can manage from a chronic care standpoint, and we need to actually put our money into those things that work and expect the outcomes that we get as a result of that. And anyway, thank you all for joining. It's great having a bunch of people here.